Okay. Good evening. So first of all, thank you, Indrajit Banerjee sir and Pradeep sir. And sorry as well because we are running 1 hour late from our expected schedule. So this session which we are going to start, it is just previous than yours. So please let us finish this the previous one, then we will jump to your session. I would like to welcome chairperson for this session.
One thing I'd like to ask, should I join 3:15 something like that? 3:15, 3:30?
Yes, you
Okay.
can join, or if you have time, you can be with us, sir.
Okay, I will
It is
finish
up
my
to
lunch
you, sir.
actually. I will finish my lunch and then I will join. Okay.
Okay, sir. So nice of you, sir.
Okay.
So the chairperson for this session is Ravi Kishan Jha, sir, Senior Psychiatric Social Worker at IVHAS, New Delhi. And another chairperson for today's session is Dr. Aditi. Ma'am, you are with us? Yes, Dr. Aditi Nath. Ma'am, you are mute. So, ma'am, as per expected, we have total 6 sessions in 6 papers in this session. And the basic details probably I have shared, but I am here with you. If you people want, I can name them one by one. But just a request to made, we are running bit behind from our expected schedule. So just don't give much time to audience for the discussion or to other diluted from the direction. Up to you. Over to you. Thank you, both of you.
Thank you, Dr. Bhupendra, and welcome, Dr. Aditi, also. Dr. Bhupendra, can you tell us what time we can provide to each of the presenters?
Sir, actually, initially, we communicated them that they can have 8 minutes of the presentation. So I must say that 8 minute must be upper limit, no more than 8 minutes is any condition.
Okay, thank you.
Thank you, sir.
Yes. May I call Dr. T? Can you unmute yourself? Dr. Aditi.
Yes, sir, yes. Hello?
Yes, Dr. Aditi, thank you for being there. You were mute from your side. So
Okay,
we
sorry.
have to start the session. So can you take a lead, please?
Yeah. Please, sure. Okay, a very warm good afternoon to each one of you present here in this session. And I welcome you all in this session on family, culture, and legal dimension in mental health. So this is a very timely and important area of discussion. I believe the 6 presenters, you will make a significant presentation, significant contribution through your presentation. As said, you so as to begin the next session in time. With this, I invite Miss Sarah. Are you here?
Yes, ma'am.
Yeah. So Miss Sarah will present her session on issues faced by women opting for abortion with unplanned pregnancy.
Yes,
Sarah,
ma'am.
over to you, please.
Yes, ma'am. Give me a second. I'll just share my slides.
And the next presenter is Harshita Shukla. Harshita, are you here?
Yes, ma'am.
Yeah, please get ready with your presentation.
Slides visible, ma'am?
Yes, it is visible.
It's visible.
Okay.
So your time has started. Please start, Sarah.
Yes, sir. Okay, so good afternoon, one and all. My name is Sara Vinsurkar. I'm from Maharashtra Institute of Mental Health, Pune, doing my MPhil in psychiatric social work. So today I'll be presenting on issues faced by women opting for abortion with unplanned pregnancy in family planning setup. It was a qualitative study. So these would be my content for the today's presentation. So starting with the background of the study. Unplanned pregnancies are a major public health issue in India. So, according to a report by the Guttmacher Institute, approximately 15.6 million abortions occurred in India in 2015, with the majority of this being unsafe. The qualitative research study conducted to study the issues faced by women while accessing safe abortion services in Family Planning Association of India, Pune Clinic. So, abortion is a complex and multifaceted issue that has been debated for decades. It involves a range of ethical, legal, and medical consideration and is often shaped by cultural, religious, and socio-economic factors. The issue of abortion is particularly significant in India given the country's large population and the socio-cultural context that shapes women's reproductive choices. So, despite an increase in awareness regarding family planning and safe abortion services, there are still many gaps in their execution. So, this is a critical issue that needs to be addressed, and as it affects the lives of many women and their families in India. The Medical Termination of Pregnancy Act, passed in 1971, provides the legal framework for abortion in India. The Act permits abortion up to 20 weeks of gestation in the continuance of pregnancy would endanger the life of the pregnant woman or pose a risk of grave injury to her physical or mental health. It also allows for abortion in cases of fetal abnormalities or if the pregnancy was a result of rape or incest. One of the most significant challenges is the stigma associated with this. Abortion is still considered as a taboo subject in many parts of the country, and women have abortion may face social ostracism and discrimination. This stigma can prevent women from seeking abortion services even when they are legally entitled to do so. So, aim for this study was to identify the issues women face while accessing safe abortion services, kind of support that women need while undergoing abortion, examine the current state of reproductive healthcare services in Pune. So this was the research methodology. The study was exploratory qualitative research study. Participants were selected from outpatient and inpatient department of Family Planning Association of India's clinic and selected using non-probative purposive sampling technique. Then a total of 15 participants were selected. The study included female participants who are between ages of 20 to 30 and have opted for abortion with unplanned pregnancy. Then tools that were used, socio-demographic profile, a semi-structured socio-demographic profile which included age, education, marital status, occupation, number of children, type of family, and number of family members. Interview guide with open-ended question was generated by researcher, and each interview was conducted for 45 to 50 minutes. Then interview transcripts were analyzed using thematic analysis tool atlas.ti. Then transcripts were organized in the structured form with broader themes and further sub-themes were analyzed and formed. So this was the thematic presentation I obtained from the analysis, which I have mentioned in the tabular form. So first theme that I obtained was reasons that were chosen by the women opting for abortion. So there were health issues, a lack of support from husband, responsibilities, other responsibilities. Then next was aspects of abortion services. So there is need for improved awareness, unaffordable for women from lower economic classes, importance of providing support and resources to women to choose to seek abortion services. The next thing was the gaps and barriers in decision making. So the sub-themes that were obtained were technical understanding, then displeasure from in-laws, prioritizing other aspects of life over pregnancy, personal conflicts, and societal pressures. And the last thing that was obtained, that role and need of abortion in family planning program. That so sub-themes were reduces challenges, prevention of unintended pregnancies, option to make informed choices, empower women to make decisions about reproductive health, control over their reproductive choices, and alignment of readiness of parenting. Then coming to the discussion, so establishing more affordable abortion centers to ensure that all women, regardless of their financial status, have access to safe and affordable abortion services. Confidentiality is a key component of reproductive health care. Women should be assured that their privacy and confidentiality will be protected when seeking abortion services. Families should be educated about the importance of supporting their female family members in their reproductive health choices. Also, families should be educated about the importance without female family members in their reproductive health choices, including abortion, without any judgment or discrimination. Also, it is crucial to eradicate the stigma and judgmental attitudes towards unmarried women who seek abortion services, and women should be empowered to make their choices. And creating awareness about abortion and its importance as a legitimate reproductive health option is vital. Then coming to the conclusion, this study highlighted that women opt for abortion services due to various reasons like financial constraints, lack of support from family and spouses, cultural stigma, and health issues. These services are not always affordable or accessible, especially for women from lower socioeconomic backgrounds or unmarried women who face opposition from their families. Addressing their challenges require reducing stigma, improving affordability and accessibility, providing comprehensive reproductive health education, and promoting supportive environments. And by doing so, we can ensure that women have autonomy to make informed decisions about their reproductive health and access safe and legal abortion services whenever they need. So these were my references, and thank you.
Thank you, Sarah, for winding up your presentation to the time. So may I seek, let me take the feedback, comment, or suggestion, or any questions. If you have any participants, you please.
Hi, ma'am. This is Justin.
Justine has
Can
suggested
you hear?
something in chat box.
Yeah, I had that same thing I wanted to tell actually. I have suggested in this one chat box, so you can go
Yeah.
through that.
It's a
Okay.
suggestion,
Yes. Thank you,
Sarah.
sir.
Ravi sir and Aditi ma'am, can I request you just take suggestions and questions at the end? That will save a bit of time. Means
Okay.
suggestion or
Fine,
questions for all in
fine,
the end.
fine.
It
In
is
the
just my
meantime,
request.
we can request everyone to put their questions in the chat box also. That will also save time.
Yes.
At the end, we will collect it and ask for them. So,
Okay.
as suggested by Dr. Bhupendra, we are deferring the discussion part, question answer session as of now, and we are moving to Harshita, Miss Harshita. Dr. Aditi,
Yes,
is it okay?
Yes, sir. Yes, sir.
Okay.
Please.
So, Harshita, please come up with your presentation.
yes, sir. Is my screen visible?
Yeah.
Okay, so my name is Harshita, and I'm currently in the final year of my BSc in Behavioral Health Sciences from Symbiosis University, Pune. And I'm going to present on the topic family factors associated with children in conflict with law in India, a narrative review. So, introduction. The Juvenile Justice Care and Protection Act 2015 defines child in conflict with law as a child who is alleged or found to have committed an offense who has not completed 18 years of age on the date of commission of such offense. Also in India, juvenile delinquency has been on a rise, with a rate of total crime committed by juveniles in 2022 being 6.9%. Now, among various factors that affect juvenile delinquency, family has always played a risk as well as a protective factor. So, now, there is some data available on the influence of psychosocial factors that might influence juvenile delinquency, and family factors are embedded within this broader context. But there is scarce information available specifically on family factors that influence juvenile delinquency. Therefore, the objective of this review was to identify the family-related factors associated with children in conflict with law in India. So the methodology is that the literature, the search term used for the review were juvenile or children and delinquency, children in conflict with law, juvenile delinquency, family aspects or factors, and parenting aspects or factors. All these search terms were used in different combinations, first in PubMed and then in Google Scholar. All the studies in the review were original studies from India, and a total of 20 articles from last 15 years were included in the study. The results. So the findings reveal that some of the common factors associated with juvenile delinquency are low socioeconomic status, broken family, parental substance use, family history of imprisonment and criminality, violence at home, low parental literacy, physical and or mental illness in the family, and inconsistent and or poor parenting. So when we dive into discussion, let's talk first about the low socioeconomic status. So when the family belongs to a low socioeconomic status, the priority of the adults in the family or parents in the family is making a living, and that might lead to less focus on children and their upbringing, and often leads to children indulging in deviant behavior. Now, in various families, because of their low socioeconomic status, children are the ones working that can, and this kind of child labor can expose them to various types of pressures and stress, deprives them of adequate supervision to keep them away from the negative influence, deprives them of education, and also exposes them to dangerous environments. The findings of a study related to low socioeconomic status is consistent with some of the previous studies done, which also found that low socioeconomic status was a significant factor contributing to juvenile delinquency. The second factor is broken family. Parental separation or parental death can lead to various psychological and emotional stress, and children can engage in delinquent behaviors as a way to cope with that stress. Also, single parent households tend to have low household incomes, and we can again face all the problems that we faced due to low socioeconomic status. Parental substance use can lead to modeling and social learning, which can lead to normalization of substance abuse and engaging in delinquent behaviors to obtain such substances. Now, all the other factors like family dysfunction, broken homes, domestic violence, all are also a consequence of parental substance use. Then family history of imprisonment or criminality is another factor that can lead to normalization of criminality. Also, when children belong to a family with the history of imprisonment, they might face some stigma and isolation from the society that can lead to dropping out of school, a lack of involvement in social or peer groups, and aggression that contributes to future delinquent behavior. Then violence at home. One of the studies included in our review stated that fathers of some of the children in conflict with law express their anger through physical aggression. Violence, whether it being physical, emotional, or sexual, can cause trauma and lead to later externalizing behaviors like delinquency. Then violence at home also leads to modeling aggression, and the children might think that the only way to solve a problem or express an emotion like anger is violence. Therefore, this kind of modeling can lead to conduct issues outside the home. Then low parental literacy. Low parental literacy among parents often leads to financial struggles in the family, and they might again resort to delinquent behaviors for the delinquent ways of obtaining money and other resources. Then low parental literacy can also lead to an intergenerational cycle of literacy, because if education is not emphasized in the family, it can lead to increase in dropout rates among the children of the family. Then physical and or mental illness in the family or among parents, although this does not directly influence juvenile delinquency, but it does influence the type of parenting in the family. And also, if one or both the parents are unwell, the children might have to take the role of an adult, and they might have to again go outside to earn, and it can again lead to exposure to various kind of stressors. Then inconsistent and or poor parenting. Inconsistent parenting often lacks setting clear rules about certain things, which makes it difficult for the child to differentiate right from wrong. Poor parenting skills might include harsh as well as neglectful parenting. Harsh parenting can lead to aggression and resentment in the child, causing externalizing behaviors like delinquency. And neglectful parenting might lead to a lack of support, and the child might try to fit in with the delinquent peers to experience a sense of belonging. The future implications of this review. So, considering the findings, mental health professionals, social workers, and educators can be trained to recognize family-related red flags in the adolescents, such as parental neglect, domestic violence, or authoritarian parenting. Schools and community organizations can play a pivotal role in facilitating family-based interventions, parenting workshops, and support groups for the prevention of juvenile delinquency. And there is also a need for campaigns to increase awareness among parents about impact of family climate on adolescent behavior. And family inclusive rehabilitation programs is also something that we can work upon. Future studies can also be done on focusing specifically on family factors, because there is a lack of data available for specifically on family factors. These then conclusion. The factors stated in this study are some of the common factors found, but one of the study also had some contradictory results. So we can say that we need more original researches on this topic, focusing specifically on family factors. And considering that, future interventions can also be planned on the same. These are some of the references for my study. Thank you.
Thank you, Harshita, for finishing in time.
No problem, sir.
Again, Justin has some questions, but we prepared with that at the end of after all the presenters have presented their studies. So Harshita, be there for answering the questions raised.
Yes, sure.
Next is Anjum Sarwar, and
Yes,
her
sir.
topic is exploring attitude and perception of Muslim youth towards music in Islam. Please.
So I'm sharing my screen.
Yes, please.
Is it visible?
Yeah, it's visible now.
Okay, sir. A very good afternoon to everyone. Myself, Anjum Sarwar, a psychology student from Magan College, Patna University. I'm grateful for the opportunity to present my work on topic exploring attitude and perception of Muslim youth towards music in Islam. This qualitative study aims to delve into the attitude and perception of Muslim youth toward music within the context of Islamic teaching. We will start from the introduction. What is music and what is music in Islam? So, music is a universal language that has resonant through human history and is a rich and complex art form. It is defined as organized sound that combine rhythm, melody, harmony, and form of expression, emotions, stories, and cultural identities. In Islam, music is called ghina, and in Sharia, which is a moral norm, it is counted as one of the greatest sin. According to many scholars like Imam Zafar al-Qasim, they say singing is a part of falsehood. All musical instruments are haram. Our earlier Islamic religious scholar Ibn Tayyibah classified singing as haram, which means forbidden, makruh, which means unfavored, mubah, indifferent, wajib, recommended, mustahab, commendable. It need to be identified what music is and what is not music in Islam culture. Here is category divided into four. In first category, there is kira, means recitation of Quran. Second, adhan, call to prayer. Talbiyah, pilgrimage chant. Hamd and naat, which is poem praising Allah and Prophet. peace be upon him. Sher, which is poet chanting, is all permissible because due to its intent and spiritual value. Category B includes music during family functions, family celebrations like wedding, recovery celebration, occupational music involving constructions, roof casting or lifting heavy metal, include chants or song during work activities, enhance rhythm and morale in labor, since that's why it is acceptable. Category C, these forms sit in a gray area and their permissibility often depends on context, content, and interpretations by scholar. Serious, material song, structured, meaningful song. Category D is sensuous and immoral music associated with bars, drugs, alcohol, and illicit sex, promotes immoral behavior and corrupt individuals and society, widely condemned and considered totally prohibited and haram. Some of the limitations or conditions where Islam permits singing. First, the subject matter of the song should not be against the teaching of Islam. Islam fights against excess and extravagance in anything, so the excessive involvement with entertainment can't be tolerated. Each individual is best judge of himself. If a certain type of singing arouse one's passion, lead one towards sin, excites the animal instinct, and dulls spirituality, he must avoid it, thus closing the door of temptation. Moving toward rationale of this study, the first is diverse interpretation of Islam. Muslim youth's view on music vary widely. Attitude towards music are shaped by local tradition. Region with strong musical heritage tend to have more accepting youth, whereas conservative areas may reinforce stricter opposition. The discourse on music among Muslim youth reflects a broader negotiations between personal belief, cultural identity, and religious teaching. Now, methodology. So, the objective of this studies were explore reason for the belief that music is prohibited in Islam, examine condition where music is allowed or forbidden, study youth attitude toward regional and music, analyze the use of musical instrument in Islam. Participants and sampling. The study targeted 73 Muslim youth aged from 16 to 28 from various districts and institutions. Participants were selected using purposive and snowball sampling, ensuring they had basic English literacy and sound knowledge of Islamic belief. Those outside the age range or lacking the necessary language and religious knowledge were excluded. Tools and techniques were used to inform constant form a socio-demographic sheet capturing age, gender, education, locations, and musical training, and a custom designed 30 question survey exploring attitude toward music in Islam. Survey distribution were done was developed by Google Form, refined with expert input, and distributed through social media platforms such as WhatsApp, Instagram, and email. Here are the result of the questions that were asked in a questionnaire. These are the questions जो हमने participants से पूछे थे, जिसमें हमने कुछ क्वेश्चंस ऐसे पूछे थे कि do they listen to music would hamper their religious belief? In their view, can excessive engagement with music be a distraction from religious duties or practice in Islam? Do they believe that music can have negative effect on spiritual well-being of individuals in accordance with Islamic teaching? Now the findings from the results are here. First, music prohibition. 72.2% says music is prohibited. 15.3% disagree. 12.6 says it depends on the content. And 2.8% believe anything diverting from Allah's path is prohibited. 65.3 says Islam discourages music. 26.4% say both. And 1.4% believe it encourages. 47.2% say music hamper beliefs. 44.4% disagrees. While on the other hand, 36.4% says music without haram elements, which means without involvement of vulgar lyrics, drugs, abuses, can foster harmony. 47.6% disagrees. Now, the conclusion of this study is that religious views and practices, a majority perceive music as prohibited or discouraged in Islam, particularly during Ramadan, believing it could harm spiritual well being, cultural tension and interpretation. While some believe music could promote social harmony when free from haram elements, others viewed it negatively, associated it with immoral influences. Preferences lean toward spirituality, appropriate genre like Sufi, Ghazal, Naat, and song with respectful non-verbal vulgar lyrics. The findings emphasize the importance of mindful music consumption is line with Islamic teaching. The study concludes that Islam encourages balance, Siratul Mustaqim, which is an Arabic word which means straight path, and enjoyment of lawful pleasure, highlighting diverse but principled attitude among Muslim youth toward music. At last, Islam is like a clear stream with well defined characteristic which is the same everywhere, but the soil over which the stream flows can be very varied. Moreover, in each case, the water will take on the color of the shore, the sand, or the earth which form its bed. Navigating the rhythm of faith, Muslim youth seek a balance where spiritual devotion and musical expression can coexist within the boundaries of Islamic principle. Thank you.
Anjum, thank you very much for your good presentation.
Thank you, ma'am.
Yeah, you please know the question raised by Bhupendra Singh sir. Moving ahead, we invite Venusia. Venusia means please, you come up with a presentation.
Vanusia is not in the list, means the candidates, those who are in the waiting lounge. And Ramesh is also not there, I think. Vanusia, are you with us?
Then Sahin,
And Ramesh Krishnan P. They both are not there. Sahin is there. Sahin Iqbal?
Yes, sir.
Yes, she is there. So this would be last presentation for this session, if others are not there. Okay, proceed, please.
So my screen is visible?
yes, yes.
Sorry, sir.
Sahin, you can start now.
Good afternoon to all respected professors, delegates, and fellow participants. I'm Shahin Iqbal, a master's student from the Department of Psychology, Magad Mahila College, Patna University. I'm delighted to present my research title, that is Comparative Study of Aggression Level Among Private and Government Hospital Nurses, conducted under the guidance of Dr. Namrata, Assistant Professor, Department of Psychology, Magad Mahila College, Patna University. So this paper is not just a comparison of two systems, it's an attempt to understand how workplace condition, emotional demands, and institutional pressure can silently shape the mental well-being of those we rely on most, our nurses. Nurses are the backbone of the healthcare system, yet they are frequently subjected to the high stress condition, long shifts, demanding patients, emotional exhaustion, and which may manifest as aggression. So now, next, we understand what is aggression. Aggression is defined as the behavior directed towards causing harm, physically, verbally, or psychologically, often triggered by the stress, frustration, or external pressure. The next is characteristics mm, aggression can be verbally or non-verbally through the loud or sharp language, that is verbally, and non-verbally through intense eye contact, invading personal space, or threatening gestures. These behavior can create a toxic environment, these burn out and decreasing efficiencies. Now, moving forward with the literature of review, previous researchers have confirmed the significance of this issue. Lawrence T. Lamb in 2014 did a study showed that exposure to aggression negatively affect nurses' mental health. And the next is Geraldo Farrell in 2001 found that workplace aggression among nurses lead to significant stress and interpersonal conflict. These findings support the foundation of this study. Next is rational. So the purpose of this study was to compare aggression level among nurses in private and government hospitals in Patna. So the nurses in different settings face unique stressors. We wanted to understand who experiences more aggression and what workplace condition contribute to it. The next is objective of the study, to compare the aggression level between private and government hospital nurses. And second one is to analyze these level using statistical method. Now the next is hypothesis. I formed two hypotheses. That is, there is a significant difference in the overall aggression level between the two groups. And there's a significant difference in the verbal aggression scores as well. Next is research methodology. So this study followed a between group design study, and for the sample, there's 16 female nurses, 30 from the private hospital and 30 from the government hospitals. And there is in between 25 to 45 years and working in the departments like gynecology, pediatrics, geriatrics, and neonatal care. And the hospital involved for the private hospital, I've taken Mahavir Vatsalya, Samay Hospital and Devlok Nursing Home. And for the government hospital, I have taken IGMS and PMCH. There are some criteria for taking nurses. To ensure reliable result, we included actively working nurses from both private and government hospitals with varying experience and shifts. We include those with the psychiatric histories, extended absence, or working in the psychiatric wards where aggression may already be elevated. Now the next is tools. I have taken aggression inventory scale by MK Sultania, consisting 67 items across 8 dimensions. And the next is, for the sampling method, I have used purposive cum incidental sampling. And the next is procedure. We have followed APA 2010 ethical guidelines, obtained informed consent, maintained confidentiality, and ensured participant that had the right to withdraw. No identifying personal or institutional data was disclosed. This study was conducted in the two phase. First phase, the data was collected from the nurses in the private hospital in Patna. And then in the second phase, a comparative sample was taken from the government hospitals. Data analysis was done by using SPSS. These are the results. So our analysis shows that nurses in the private hospital score higher in aggression, particularly in the verbal aggression compared to the government hospital nurses. The likely contributing factors including greater workload, job security, and the rigid management practices. This likely contributing factor include in contrast, government nurses benefit from the more job security, less performance pressure, and structured policy, which may help reduce aggressive responses. This statistically significant difference confirms our hypothesis. Now the next is conclusion. These findings confirms that workplace conditions play a significant role in shaping aggression among nurses. To address this, hospitals, especially in the private sector, must implement supportive strategies to manage stress, reduce pressure, and improve emotional well-being of their staff. And the next is some strength and strategies to manage aggression based on our findings. Regular stress management workshop in both settings, adjust workloads, especially in the private hospital, promote open communication or teamwork, recognition and reward system to boost their morale, and establish a supportive culture that value mental well-being as much as clinical outcomes. There are some limitations, like any research. This study has also its limitation. The size is small and the limited region, that was specific region in the Patna, so findings may not generalize nationally. Self-report bias may have affected how nurses rated their aggression level, and we do not account for individual personality traits or job roles, which may also influences aggression. These limitations open the door for more detailed large-scale research in the future. At last, future implication, introducing stress management program and mental health support for the nurses, improve communication and teamwork in the hospital settings, conduct broader study with the larger and more diverse samples, and use finding to inform healthcare policies and enhance nurse retention and patient care. Aggression is not just an individual response, it's a reflection of the environment we create. When those entrusted with the healing begin to show sign of emotional strain, it's not just a personal use, it's a systematic call for change. These are my references, and that's all. Thank you.
Thank you, Shaheen, for making a very systematic presentation. Ravi sir, I think we can open the floor for question answer session.
Yes. Maybe. Okay, ma'am. So the other two presenters are not there, I think. Ramesh and Vanusia.
I was
Hello?
just trying to find them out.
Uh,
Vanusia non
They are not there, I think.
Vanusia Ramesh Krishnan P. Absent. No one is saying
Sir,
present.
it's me, Venusha. I am here.
Vanusha.
Yes, yes,
Okay,
sir.
Vanusha. Yes, yes, yes. Please. Sorry
So,
to pronunciating it wrong.
It's okay, sir.
so we can let Vanusha to present her paper, and then we can go for question and answer.
Okay. First of all, good afternoon to everyone. And first of all, I would like to thank for accepting my abstract, and I'm able to present today. And going forward with my presentation.
Vanusha, can you share your screen, please?
Sir, is
Yes,
it
it's there. It's there. Yes, please.
okay, sir? So the title of my presentation is A Family-Centered Psychosocial Approach. One minute, sir. A family-centered psychosocial approach in the management of dissociative disorder, a case study from rural Bihar. Myself, presenter Venusha Notsap, doing MPhil PhD first year in Central Institute of Psychiatry under the guidance of Dr. Prashant Shrivastava and Mr. Atola. So the introduction. Dissociative disorders often manifest as unconscious responses to psychosocial stresses, especially like women from rural settings are particularly vulnerable due to their gender roles, stigma, and lack of support from the family, society. And this case is exploring the interaction between family dynamics, having high expressed emotions from the family, and psychiatric relapse. The aim is to highlight the relevance of systematic, cultural informed psychosocial interventions. So here is a social demographic profile. Index patient PK is a 30 years old married Hindu female. She is educated up to Bachelor of Arts and she has not been working since. She is a homemaker hailing from a lower middle socioeconomic family of rural Bihar. And she's living with her family consisting of 9 members who lived in a 2 rooms in their own kacha house with no adequate space and facility. The personal history suggestive of congenial home environment in childhood with inadequate parental supervision and behavioral control. This is the clinical presentation. So during the examination, psychiatric examination, the complaints was like when the index patient came to CIP 5 to 7 days before, she was noticed some changes in behavior in which the family reported that she would get angry on silly matters, she would shout, yell at her family members when asked to perform any task or when her demands are not met. Her condition got worsened and she starts verbally abusing her family members. And the patient also was observed with low mood and energy. As informed by the family, over the past 4 days, she was not interacting with anyone. She was also not perform any household work, stating that she is feeling weak. So the informants also reported that the patient was seen crying multiple times in a day, but she would not give any reasons since the past 1 week. The patient was also not able to take care of her toddler in which she was having 4 children, and the youngest was 1 month old when the time she came to CIP. And the patient was also suspicious towards her in-laws and other relatives, saying that her toddler have been kidnapped, because during that time when she was symptomatic, the baby has been handed over to her maternal family, and which is why the patient thinks that they have kidnapped her child. And then after giving her the assurance that her baby is safe still then, also informants reported that the patient would be seen wandering at home and she would also refuse to eat and drink. And when asked her to eat or do so, she would get aggressive. And also, informants informed that the patient experienced loss of consciousness, where her eyes would be closed for a certain period of time, like for 2 or 5 hours, thrice in a day. Like whenever she is symptomatic, then the relatives came to know that she has again relapsed. Hence, they have brought her to CIP for further treatment. Family history and dynamics. Index patient is staying with her in-laws after marriage, husband and 4 children, in which the youngest daughter is 1 month old. And boundaries, the findings was the family does not follow any, does not involve any outsider in the family matter, and hierarchical leadership is being followed in the family, in which the nominal head is the patient's husband, and the functional head is the father-in-law. The patient's husband has not much power, as he is financially dependent on his father, and he is not having any job. Express emotions was also one of the finding. Due to the birth of daughters, the patient is having one son who is the eldest, and the other 3 children are the daughters. And also, like, there was an unpaid amount of dowry from the patients. Hence, like, there was an express emotion towards her. Role burden, the index patient reported of role burden, as she has to perform the household chores and looking after her children. Lack of emotional support, the index patient reported of lack of emotional support from her husband. The psychosocial assessment tools, McMaster Family Assessment device, has been administered on the patient's husband and the patient herself during her stay at CIP in the RHC ward. The findings were dysfunctional problem solving and general functioning. And the family attitude scale, it was administered on the patient's family, in which severe criticism towards the patient was the finding. And level of expressed emotion, it was administered on the patient, which shows severe emotional neglect from the family. Psychosocial formulation. Index patient is a 30 years old married Hindu female, educated up to 12th standard, is a homemaker hailing from a lower middle socioeconomic family of rural Bihar. The family, consisting of 9 members, lived in 2 rooms in their own kacha house with no adequate space and facilities. Personal history suggestive of congenial emotional environment during childhood with inadequate parenting, supervision, and behavioral control. Currently, in life cycle family with preschool children, the oldest child, uh, 2.5 years to 6 years. The family dynamics reveal close external boundary and clear internal boundary, along with dysfunctional in the couple subsystems. Direct communication is present in the family. The father-in-law serves as a dysfunctional head of the family, while the patient's husband is the nominal head, exercising democratic decision-making role burden present in the patient. There is inadequate reinforcement, behavioral control, and adaptive family members. The findings from McMaster Family Assessment Device interprets that there is dysfunctional in problem solving and general functioning. The family attribute scale shows that there is severe criticism and in the level of express emotion scale shows that there is severity in perceived lack of emotional support and moderate in perceived intrusiveness. The risk factors, lack of support and stigma is there. Maintaining factors, poor problem solving and family criticism. Protective factors are the sibling support and willingness for help. Individual interventions has been done with the patient. So psychoeducation on dissociation and stress, in which sessions have been taken with the index patient, where she was explained about the nature of illness and the role of stress, which is triggering towards her illness. Activity scheduling during her stay in the ward, the patient was motivated to engage her in meaningful activities by reinforcing structure, purpose, and joy, and has also motivated her to follow the same after discharge. Emotional regulation. Patient was also explained about the ability to understand, manage, and respond to emotions in a healthy way. Cognitive restructuring. The index patient was explained about how thoughts trigger an emotion and affects what she behaves. Supportive psychotherapy. During her stay in the ward, index patient was distressed, thinking about her children, and wanted discharge. Since this reason, then she had one episode of dissociation. Hence, she was ensured about her children's safety and explained about applying supportive principles in everyday coping and build emotional resilience. Family interventions. It was done with the patient's husband. Sessions to reduce expressed emotions. The session was conducted with the patient's husband and explained about what expressed emotions are, how high expressed emotions affect individual with mental health condition, and exploring strategies to reduce high expressed emotion and support recovery. Role restructuring and shared caregiving. The session was conducted with the patient's husband regarding distribution of role, impact of illness on family roles,
Venusa,
recognizing the importance.
Venusa, sorry to
Yes,
interrupt you.
yes,
You will, yeah, sorry to interrupt you, but you will get extra 1 minute only. Your time is already up to
okay,
wind up
ma'am.
your presentation.
So, yeah, so role restructuring and shared caregiving was done, explaining about the husband of how he can help with the patient at home and also improve communication and parenting support by making them understand, like, to foster emotional resilience in the children. So these are the methodology for psychosocial management that was done. Challenges faced was limited spousal engagement at the initial time, then patient anxieties about caregiving, then cultural stigma around mental illness and gender. Outcome, improve emotional stability and insight. There was increased family awareness and cooperation. And during her follow-up at CIP on the OPD basis, she reported that she's maintaining well and her family have also like understood her compared to. And conclusion is family-centered interventions are essential by identifying ways why families can be involved meaningfully. And cultural sensitivity enhances clinical effectiveness by recognizing how culture influences mental health perception and care. And more importantly, is about the role of PSW in rural mental health. Thank you.
Thank you, Vanusa.
Ravi sir, please.
Yes, ma'am.
Yes, ma'am. Vanusa wants to say something?
No, sir.
No. Okay. Okay. Thank you, Dr. Aditi. So as suggested, now we can take up questions. We can start for any question regarding Vanusa's presentation. One by one can take up. There is nothing in chat box regarding her presentation. So if anyone has anything, he can unmute and share the question or suggestion. What? Well, Aditi, madam, I don't think
Yes,
that yeah, there are anything. If you have anything to say,
could not find. I think Justin sir has shared his observation for Sarah.
hmm. Yes,
Sarah,
Sarah and Harshita
Yes,
also.
ma'am.
I think you have noted.
I
Sorry.
think Justine had asked for objectives in
Yes.
with reference to Sarah's presentation, and Sarah has shared it in the chat box. She has
Yes,
answered it. Uh,
yes.
Okay.
so that was one part she might have missed during presentations. So there is nothing to worry about. So regarding Harshita's presentation, Justine again had one query. If she had followed any guideline for review of literature. Harshita?
Yes, sir. So, sir, since this was a narrative review, I did not formally use any Prisma guideline, but I just strictly adhered to the inclusion criteria for my study, for my review.
Okay. So, but you must have some basis na, for even for setting up your criteria, inclusion or exclusion. So that is a suggestion from Justin, I think. है ना? So for future, you can take care of that also. That
Yes, sir. I'll take care of that in my future studies.
Prisma is very important tool to conduct narrative reviews. You please take care of it.
uh,
Sir, if I may be
uh,
allowed.
yes, please.
Yes.
You can.
Two comment. One, I would like to just replace Justin's has comment as he has mentioned that suggestion to reducing the investing time to present introduction and other
Mm,
part. Yes, I think that that is applicable on most of the presenters part that they have invested most of the time to explaining the introduction and the review
mm,
part
mm,
that somewhere controlled them to
mm,
talking about the methodology and findings
mm,
along with the
mm,
conclusion and or
mm,
recommendation part. So that must have been taken care.
mm,
And another suggestion related to Anjum's presentation. She
mm,
has conducted her research
mm,
with the help of Google Scholar, and that was actually framed and it was expected to control or include a specific group basically.
mm, mm,
So she must have used because it was a social media platform from where she picked her participants. So
mm,
that eligibility of the participants for participating in the research was a kind of questionable thing.
mm,
Because, for example, if I picked, I don't know the basic rules, regulations of the Islam and the utility in the
mm,
religion,
mm,
utility of the music in the
mm,
religion, but
mm,
I just responded in that. So
mm,
that part, I think she must have developed some mechanism to control that, so that people, those who are eligible, only
mm,
they would respond to it. So
mm,
that is just a suggestion. For future, she might take care for that.
mm.
Rest nothing to say.
That's a very good suggestion from Dr. Bhupendra. Anjum must have noted it. And I
Yes, sir.
have
Thank
one
you so much
suggestion
for the
for
suggestion.
Anjum. matlab, she can even Justine had asked for to her if there are any limitations or future directions that she see during her studies. So if she has anything to say about that, or even to Dr. Bhupendra's suggestions. Anjum, would
Yes,
you
sir.
like
So
to
for
answer?
limitations,
limitations of your
Yes, sir. For
studies.
limitations, yes, sir. So the study may not capture the diversity of opinion within
Uh,
the Muslim community.
mhm,
And so second is topic is very debatable, and future research need to be continued on that.
mhm.
And so for future direction, it would be exploring intersectionality of attitude toward music
Mm.
with other aspect of identity, like on the
Yes,
basis of gender. So it can be helpful. That's also.
yes, yes. Good. Very well answered, Anju.
Thank you, sir.
You can. So, anything else, Dr. Aditi? It's handed
Uh,
over to you now. Anything else that you want to point out?
Sir, though I had few questions, but due to time constraint, I will not go ahead with it. Though
But
I
you
was
can
looking
suggest to presenters.
that for Sarah, you
Yes,
have
ma'am.
highlighted that, yeah, marital status and age, that I got your point from the presentation. But did you observe differences in experience based on caste and religion?
No, ma'am.
So
Actually, the
for
institution from where I collected my data, there wasn't any kind of discrimination participant faced.
okay, that means you don't have any specific caste and religion based data with you.
No, no.
Okay, okay, okay. Thank you. But in future, you can look at it,
Yeah, ma'am. Sure.
look into this aspect.
Yes, ma'am.
Okay.
Yes,
For
thank you.
Harshita, definitely for narrative reviews, Prisma, I would suggest in future you do. And since you belong to this Gen Z category, and I'm a mother as well of 8 years son, I would like to uh, know, or I'd like to hear from you that uh, how will you address the issues faced by modern family, which is nuclear by structure and dual working parents these kids have, and that too in the era of digital media?
So, ma'am, I think the best way to intervene in prevention for such families would be through school. Schools can have a parenting workshop for the parents where parents can, especially if both of them are working, they can make some time and attend that workshop on how to balance the work and also how to take care of the child at the same time.
Okay, okay, thank you. And then Anjum, you have made a very, or in fact, all the presenters, you have made your work, presented your work very nicely. For you, were there any generational or gender differences uh, in how Muslim youth perceive music and its acceptability in Islam? Generational or gender differences?
Mm.
No, you said no. Muslim youth, they said, right? So I thought youth, is there any gender differences?
Anjum,
It's
you
not.
are mute. If you are responding, please unmute, then respond. Ah,
Ma'am, can
yes.
you repeat it again? Sorry, I can't hear that.
Yeah, you used na, Muslim youth.
Yes, ma'am.
So youth means you have covered this both genders,
Yes,
or is
ma'am.
there any
Both.
gender difference?
No, ma'am. Both male and female.
Have you come up with specific conclusion, gender specific conclusion?
Not
No,
specific,
no,
ma'am. It's
okay.
all.
Yeah, 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 fine. But in the
Any
youth,
any significant difference between your sample itself? I mean, male and female. Sample size. Any gender difference.
Okay, no
I-
issue. Yeah.
Okay.
Ravi sir, would you like to add anything?
Yes, can I ask Shaheen? I have some question regarding her presentation.
Yes.
So, if we have time,
Yes,
Dr.
Sir, please.
Bhupendra and Dr.
Sir,
Aditi,
sir,
please.
please.
Yeah.
Yes, yes.
Yes, Shaheen has presented about the nurses, this thing well-being, but she has compared the government sector nurses and private sectors. I want to ask if she has categorized, has subcategories for nurses working in the private sector. Like there must be different work cultures in charitable hospitals, then corporate hospitals, then some private nursing homes, because private, I think it's too diversified as compared to government, because there you can say that job security itself is a major determinant. So have you subcategorized that also? And if not, then you can take care of that in future.
Yes, sir. I didn't, but in the future, I
Hmm.
keep in mind when I am doing further researches.
Okay.
Okay. Uh, and from my side, I would like to definitely congratulate all the presenters. Through your presentations, you have presented uh, critically the intersections of, I must say critically, the intersections of health, psychology, family dynamics, then culture, and each and every topic uh, uh, is holding significant relevance in contemporary social discourse. And again, understanding the issues faced by families opting for abortion, definitely through your presentation, um, you have shed lights on reproductive rights, stigma, and access to healthcare in India. And it was a quite learning opportunity for me to listen to you, Sarah. And similarly, examining the factors, the second presenter associated with children in conflict with law, that definitely helped us again to identify the root causes like family dysfunction, socioeconomic deprivation, and lack of community support, which are very, very essential for effective juvenile justice reform. And this was again very enriching knowledge, enriching information for me. So thanks to you too, Harshita. And the third one is exploring attitudes and perception of Muslim youth when we are talking about that uh, youth population, we have maximum youth population, then definitely conducting any study on youth gives a lot of opportunity and scope for uh, future research. Through your study, definitely it reveals the complexities of identity, cultural negotiation, and religious interpretations in a rapidly globalizing world. At least through your research, we got an opportunity to understand the minds of young Muslim youth. Thanks to you. And next, that Shaheen, uh, no, Vanusa, through your research on family-centered psychosocial approach in the management of disassociative order, definitely it helped us to underscore the value of culturally sensitive and inclusive mental health interventions, especially in rural areas. And lastly, the comparative study already Ravi sir has highlighted on aggression level among nurses in government and private hospitals. Definitely, it highlights the workplace stress, then organizational culture, and the need for better support system in healthcare sector. So, altogether, these topics offer a multidisciplinary understanding of individuals and collective well-being in the Indian context. So all of you, please continue working hard. We would like to see you in different other platforms in near future. All the best. Over to you, Ravi sir. Thank you. If you want to
Thank
make
you,
any
Dr.
concluding remarks.
Aditi. You have already summarized the session. So, without wasting time, we can hand it over to Dr. Bhupendra for further this thing.
Thank you.
And thank
All
you,
the
thank you, Bhupendra sir, for giving us this opportunity, at least giving me this opportunity. And it was a really learning and enriching session.
I have already thanked him.
And Ravi sir,
Okay.
session with Ravi sir, it is again, it's a
Thank
privilege
you.
for me.
Thank you.
Thank
Thank
you,
you all
sir.
the presentees for your wonderful research work, sharing with this on this ISPSW conference platform. And thank you both the chairpersons for enlightening us and handling this session very beautifully. Thank you so much. Okay, now we are moving to our another session that is our defined as free paper session F, social work policy and professional practices. So for chairing this session, I was just looking into the chairpersons, and then Banaras came in my mind. They both started their academic journey from Banaras. So first, Dr. Inderjeet Banerjee, sir, is they both have few things very common, and the first common thing is Banaras. Then the second common thing is MPhil in psychiatric social work from Central Institute of Psychiatry, Ranchi. And the third is the field of psychiatric social work. So that is making some difficulty as well as easy to me to introduce both of them. So first of all, I would like to welcome Dr. Inderjeet Banerjee, faculty at Department of Psychiatric Social Work in
Thank you, Bhupendra.
Lokpriya Gopinath Bardoli, Regional Institute of Mental Health, Assam. Welcome, sir, to the session.
Yes, thank
Second,
you.
I would take opportunity to welcome another chairperson for this session, Dr. Pradeep Kumar Pandey. Sir is another centurion. In the morning session, we were talking about centuries in the centurion. So his centuries are towards the publication side. I believe that either he has touched it or he is about to touch. So I wish if it is lesser than 100, then he could able to touch this year. Welcome, Pradeep sir.
Thank you, Dr. Bhupendra.
So over to the chairpersons. The session we have scheduled, and all. I share the details with you, but I can read the names or any details if you want. Let me know. I'm here. Just one request, because we are running bit behind schedule. So as 8 minutes were scheduled or allotted to the presenters earlier, so I would not say that cut their time, but I must request that don't allow any further timing from the 8 minutes. Thank you, sir. Over to both the chairpersons.
Thank you so much, Dr. Bhupendra. So we don't have enough time. We have already late. So I invite first presenter, Kumaran S. Title Faith and Practice, a Comparative Analysis of Christian Value and Social Work Principle. So please, Kumaran.
Yes, sir. Yes, sir. I'm here.
So,
yes, sir. I'm here.
Please proceed your presentations.
Okay, sir. Thank you. Hope my screen is visible for you, sir.
Yes.
So, okay. Good afternoon, everyone. Thank you for this wonderful opportunity. I will just straight away walk you out through my presentation. The presentation says that compared faith practice, a compared analysis of Christian values and social principles. So, I am Mr. Kumaran. My co-author is Mr. Priyadarshini K. So, we've been working as assistant professor in Hindustan College as well as Vaishnav College. So, first one is introduction. So, you may be wondering why this guy out of nowhere having this topic. So, in my presentation, I mentioned Christian faith in red color font, and social work practice in blue color font. And wherever it is any convergence or any tensions, I just mentioned as in green color. So first one is the purpose of the study is to explore the intersection between Christian ethics and social work principles. So they were like if you see the history, we can be easily find out
Sorry
there
to
were
interrupt,
so many
but
mutual
Kumaran, do it in a
mutual
slideshow
topic.
mode. Please do it
Okay.
in a slideshow mode.
Okay. Now it's okay, ma'am?
Yes, it's okay now. Now you can proceed.
Okay. So there were, sorry for the interruption. So there were so many things were common for an Christian values as well as social principles. And next one is important is the faith always influences the values, irrespective of any religion or like even there is some people will be following there is no God, they be called atheists. So irrespective of their any things, their faith always influences values. So we're gonna see about the shared values and what are the areas of tensions and what are the areas of models of integration. So these were the basic social work values as well as principles. Service, justice, justice, dignity, worthy of the person. We already well known about this. The next one is these were the Christic and ethical values. So from the bibliography, this is about compassion, justice, love of neighbor, stewardship, humility, faith, and hope. So I just it's an empirical research study. So I always wanted to do a full-time research on this particular paper. So I just worked on a minimal effort. It's a narrative case analysis, and I just worked thoroughly on the primary data sources which has been collected from personal field experience, informal conversations with Christian social workers, and also from the ethical journals and informal expert consultations. These were the tools I just utilized. So area of convergence. So the common areas like common conflicts, service and compassion. Like both of them shedding the blade for their empathy side for the people who are in need, especially people in marginalized. Either it's a social work or it's a Christian faith, both of them what laid their hands on helping the marginalized. Justice. Next one is both of them are make sure they're getting doing advocacy in terms of social as well as economic equality. And the third one is dignity. So as social workers, we know that everyone is every individual is unique and different in nature. The Christian also mentioned that even though the person is irrespective of any work and all, any they're born from any different religion, if they're following Christianity, they should be valued with the respect and relationship. So community and love are central terms. So if you know that there is a two sides of a coin, if there is a head, there will be tail. So then let me just introduce the tail also. The areas of attention. Inclusivity with doctrinal boundaries. So social work says that we need to include every person, in terms of gender, in terms of caste, class, race. But in Christianity says that we can't force other people to follow the Christian religion because it's out of their context. The Indian conscience says that we can spread our religion and promote our religion, but we can't never make one to follow their other religion. Next one is autonomy versus religious authority. Autonomy in the sense, social worker can let the client decide what are the decision they want to make at the end of the day, because principle of client self-determination. But here, religious authority says that whether they are making any decision or not, they should be in the Christ-centered decision making. They should be rooted in Christ. So that is Christianity. And here is said evidence-based practice, but here is faith-based interpretation. Out of nowhere, at one point of time, we should be blindly following in a religion because we believe in faith. Faith is saying that something we cannot see, but we need to, if we are believing that particular thing it will be coming, we'll be put these things in prayer and we'll be waiting for. The next one is challenging pluralistic and is secular settings. We can follow anything. There were so many methods and social practices, but here we should be only following God. God is our master. What and all He is commanding, what and all He is cited in the name of a Bible or any religion book, So it should be followed. So these are the areas of tension between a social worker and so they were the case examples. We'll be just shortly narrate one case. So the expansion of LGBTQ is say the lesbian, bisexual, gay, transgender cure. But in recently just gone through one real LGBTQ means let's get biryani together quickly. So being a Christian, I can make sure a LGBT person can attend the prayer service, but they should be leaving their physical context in the in the doors of the church. They cannot practice. They cannot practice what they could do in the physical in the churches. So, being a Christian social worker, I also accept the client as an LGBT person in the field and also in a church. My religion says that they were not allowed to be church. So, but few pastors are allowing church because in modern days Jesus says that, like in Christianity says that we should allow every other people because God says that love yourself like you love others. So we should love ourselves. And even balancing spirituality and logical things are very rare. So these were the case examples. And what are the ethical integration we can be faith informed practice? We should be make sure whether which religion the client can be depends upon which they laid foundations, because out of nowhere, imagine we are making any religion impact that will like disturb their foundation. And second one is ethical reflection. So you think faith the guide, because in a normal counseling, if he used to visit a pastor for a counseling, at the end of the day and start of the session, they'll be having a small prayer, word of prayer for the session to be carried by the spirit. So, but in secular, we can't make sure that, because some people will be saying that I'm atheist, there is no God like that. But the next one is collaborative models. There should be interfaith and secular partnership. And I'm just quickly concluding for the implication for practitioners, we should make sure they're respecting both professional ethics as well as faith identity. And for educators, integrating value discussions and training. Policy makers recognizing diverse moral frameworks. Conclusion: faith and professionalism can coexist with mutual respect, as well as there are some models which accepts both non-vegetarian and vegetarian, but only few models say that only fully vegetarian, no non-vegetarian also. And second, need for ongoing dialogue and ethical reflection. In this generation, in this 21st century, faith cannot be ignored when we completely work as a secular person. It's also need to be it's one area we need definitely to be visited. And third one is invitation to faith as a source for compassionate care. It can be considered as one of the method to console, to change the client or change the situation of the client. So these were the bibliography I just cited in my thing, and thank you so much.
Thank you, Dr. Justin.
Anyone have any queries, questions? Someone have written something in chat. Presentee may answer. The question is there any reference for ethical terms you have used for Christian? Because you simply you cannot use words when religion comes. It is more sensitive matter. So try to include reference in such cases. Any clarification from the presentee regarding this question?
I will. Yes, sure. So I will try to include the ethical terms from the future residents. We just completely worked on that, like as I mentioned, that primary data complete from that, informal field experiences. So for that, I can't provide that concrete evidence, but it's from the informal field experience. There's one particular that was my including from that conversation only. But in future, I will definitely make sure I just involve everything, include everything what all you said. Thank you so much.
Anyone else have any query or want to contribute? Anyone?
Yeah, I have one question to the presenter. Mr. Kumaran, when you present this type of, but this is not a question, rather it's a kind of feedback you can say. When you go for this kind of presentation, no, it's always better you give plenty of references.
Okay,
And
okay.
one question I have, that when you don't believe in something, some rituals or some process of the society, when you don't believe, then how can you practice that ethically?
Yeah, it's a good question. I always use the expert question when I just open the context of the religion. Yes, ma'am. Like it's very hard for making us to believe one person if there is no belief. So there will be some people call there is no God. Actually, their belief system say that there is no God because they are following one particular thing which they can't name it. But even like what before I'm just starting this presentation, uh,
Hear
like
you, I think.
being
Yeah.
yeah,
If
yes, yes.
your voice broke,
Okay,
will you repeat?
wait.
So now I'm audible, sir. Hello, sir. Now I'm audible.
Yeah, now I can hear you. Others?
Okay, sir.
So it was about ma'am was asking that how can you make sure one person to
To believe,
believe?
No, it is echoing. Now it is echoing, started echoing your voice.
How about now, sir? Now it's
Kumaran, use only one device at
okay.
one place. Yes, you are audible. Please.
So the answer for the question is, it's not everyone's cup of cake, a cup of coffee to make sure one person is to believe in one particular thing which they never wanted to believe, never wanted to follow. At the end of the day, like being a social worker, we should make sure whether we need to change the client or change the client's environment, irrespective of any religion. Every human being having one particular thing like their belief system. Either some people believe in God and other people believe in their self. So we should make sure to enhance their like what are the self-esteem, self-respect, self-confidence, what other things can be enhanced. If you are able to like developing such interpersonal skills, it will be very easy for a person to be guided and guarded with the responsibilities. In terms of religion, religion can't be included in everywhere and anywhere we wanted, because it's a very sensitive topic. I know that, but if that person is not having any belief system, definitely they will be having belief on themselves. Like, so we need to touch on that concept correctly. If you are working with the right people at the right time at the right concept, everything will be achieved and accomplished at the right times. So that's my answer now. Like I'm just I hope I'm just able to cover it. If there is any suggestion also, question also, you can shoot it up.
Okay. I would like to ask the chairperson how much time we have for discussion, Dr. Bhupen.
Sir, actually, chairperson is you and Pradeep, sir.
No,
I'm
how
just
much
your
time we have?
I
For
am just
presentation,
your
7 minutes you have
facilitator.
allotted.
8 minute was given for presentation and 2 minutes for discussion.
Already we passed that. So
6 minutes, yes, sir.
yeah, so I think we passed that. So we will not take any more questions.
Sir.
Pradeep ji, from your side, your comments, then I will comment.
Okay, I'm audible.
Yes.
My question is from Kumaran, Dr. Kumaran.
So Mr. Kumaran, sir, not doctor.
Mr. Kumaran. So, what is the practical implication of presenting this paper? Because in India, only 2.3% people belongs from a Christian religions, and most of the people do not familiar with what is the ethics, what is the principle of Christianity. So, tell me, what is the practical implication of this paper?
So my ultimate desire to bringing out this topic is to make sure social workers are not belongs to any religion. It's also belongs to Christian also. Because so there were so many people in the name of social works, they're like also promoting their own religion. Even like I would just want to contribute from myself. Christianity is also having some like history in the name of social work. So charity, like charity starts at home, not only like other religion. No, it's big. It's like it starts from everyone, irrespective of the religion. So my main idea is to like what like social workers having some
So I understand, Kumaran. You empathize that the history of social work is
Bhupendra,
started from the cause. You
yes,
are telling like this, and most of the Christians contributed a lot in the development of social work. You are trying to say it like that.
yes. Yes, sir.
But,
So not
but
not Christian alone, every religion contributing. My concern is Christian also contributing, but make sure every church is like understand their particular value. First, I need to empathize my people, like social workers, not in different language. It's in our own blood. In our own religion. If you are doing that, there is no need of like any other. We need to depend on any other service. If
so
churches are started
you
doing
you 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 have used most of the time the Christianity language. My question is, nowadays we are emphasizing the Indianization of social work.
okay.
You understand? So what your paper contributes any significance in the Indianization of social work? Because Christian and Islam is not a religion from Indian origins.
Yes, yes. It's from the Western region. I know that.
And another things, nowadays uh, it has empathized that Indianization of social work. So in Vedas, in Upanishad, so many charity work conducted throughout the lives. So it's need to implement ads such a Vedas, such a Upanishads in current scenario also. And another things,
sir, sorry to interrupt. We are
yes.
just time is
Okay.
we are
Okay.
just
Okay. Okay.
discussing first
Okay.
paper only
Okay.
of the
Okay.
session.
Just I want to say in a few words,
Okay.
UK and USA both is a Christian dominant country.
Okay.
Yes.
Yes.
And British rule, you have glorify very nicely about the gender equality and non-discrimination, so many terms. But in America, 74% people belong from a Christian religion. A huge racism has been found in this country. In
Okay.
Britain, ruled 190 hundreds year from to this country, and the what you have used the term secularism.
Yeah.
Didn't found any secularism in that period. So
Okay.
I think your paper should be neutralized. I
Okay.
understand that so many add-ons.
Sir, again, I am jumping. I think
Okay.
Mr. Kumaran was just intent to express the social work professional part existing in the Christian religiosity. He was not propagating or he was not promoting the religion. He was just
Why,
trying to.
why only Christianity? Why use the term Christianity? It has already present in Hinduism, in
That
Sikhism,
was his decision to narrow down his presentation, what I believe.
all,
But I think
all,
we must
all,
move from this
all the
discussion to
reasons
next one.
mentioned
Doc-
about the term
Dr.
non-discrimination.
Bhupendra and Pradeep sir, just to interrupt one thing, just to gist what Pradeep sir has said, actually the concern is professionalism in any profession, not only social work, through any profession, you can't promote religiosity.
Yes, yes.
Agree. Yes.
That is
Both
the
are
main
entirely
thing.
different. Agree. Totally agree. Both are
Sikhism,
entirely different things.
So,
Buddhism, Jainism,
in
Hinduism,
every
all,
religion, in every religion, take it any
yes,
religion, there is a
yes, yes,
concept of social work. But we are not doing social work. We are a profession. We, as a
Yes.
profession, it is better not to promote any religion.
yes, exactly,
Obviously, in
exactly.
our religion, there are many concepts, there are many ways to do for the welfare, many ways to do the welfare of for the people, for the society. But we should keep a boundary. What is
Yes.
charitable social work and what is professional social work?
Yes, exactly. I totally agree with Dr. Sabri.
I hope
Can
Yes,
I
Kumaran
share
would agree
my
with
views?
us.
Can
Sir?
I share my views?
Yes, sir. Please.
Yeah,
So,
yeah. Thank you, Mr. Kumaran. In my view, basically, what I could get from your presentation, for me, like each and every religion have some common things. Whether it is our what we are following, majority of in India, for say Hinduism or any Muslimism or Christianity, all religion have many things common. But whatever little bit knowledge I have regarding Christian religion, two things are required, three notion. One is you must have faith in God, and second one, you must have fear of God. So these may not match with Hinduism, because if you don't believe, you will be called secular or tagged something like secular or communist, something like that. Means you atheist. There are so many words. But in Hinduism, a third dimension is there. One is that is called jigyasu. Means we don't know whether God is there or not. We can go for searching the God, whether it is there or not. So that is one difference. But paper was not about whether we believe on the religion or not. But the people we are dealing with, they have some this or that faith, most of them. So in that way, social work is very much related to spirituality and religion. That way, it is okay for me. I don't think you are trying to promote your Christianity. That is there. And uh, second thing, like your this one, you what you have talked about the Christianity and social work, many things are there in social work. Like we started our social work started with charity and all, neighborhood. What you have talked, so many things. But one thing, one suggestion, like now we are moving from those charity and relationship to the patient rights, right-based practice, and what is called their their strength-based practice. So these two aspects, any religion, I will not say that these strength-based and your right-based things are not there in religion, but when we talk about the integration of religion and social work, you need to focus on these aspects, because now we have shifted from all those welfare and charity towards social work is now more moving towards the strength-based and the legal right-based approach. So thank you. With this, I will stop my saying. Thank you for your presentation. Nice presentation.
one closing argument from my side. So I just want to make sure I may be like what the things which are like interpreted may be misleaded. So I just want to close in one sentence. I am not here to promote Christianity to social workers. I'm here to promote
Yes.
social work to my Christian fellowships. So that's my
Yes.
ultimate concern. If there is like any like misinterpretation from my side, I'm sorry for that. And thank you, Mr. Bhupendra Singh, for explaining for that my presentation privilege. So thank you so much. Thank you for the wonderful opportunity. So we Indians work social work wherever we go, irrespective of any religion, caste, class, anything like that. So that's the ultimate aim of this presentation: promoting social workers to every religion, especially to my religion. That's all, sir.
Thank you.
Right,
Thank you.
Kumaran. I must. Yes, sir.
Thank you.
So just I am again interrupting in between the session. I should not, but I have to. I just like to request to chairpersons. Can we allow all the presenters to present, and then you can go
Yes,
for
yes,
question
yes.
answer and the discussion. That will
Yes.
save some time.
Okay. Totally agree with Dr. Bhupendra. First, all the presenters present their presentations. After that, we will discuss about that. So I invite
It's
next
okay.
presenter,
Anil.
Anil.
Yes, sir. Can I share my presentation, sir?
Yeah, sure, sure.
Is it visible, sir?
Yes, yes.
Very sure. Okay. Good afternoon, everyone. And
Yes, yes.
I am Anil Kumar, PhD scholar, Department of Social Work, Central University of Himachal Pradesh. Currently working as a medical social service officer at AIMS Bilaspur. I am grateful to be here and thankful to the organizers for giving me a chance to present my paper here. So the title of my research paper is Occupational Stress: A Systematic Review of Causes, Consequences, and Mitigation Strategies. Sir, I think my slide is not moving from my side.
No, not moving.
Okay, now is it moving now?
Yes.
So, okay, sir.
Okay, sir.
Occupational stress has become a significant challenge in modern workplaces, affecting employees' mental and physical health while reducing organizational productivity. The increasing demand of modern work environments have greatly contributed to the rate of workplace stress. Stress arises when work requirements exceed the cognitive and physiological mean available to an employee, risking numerous health issues, including mental, emotional, and physiological ones. The effect of stress are not limited to the individual employee, but also affect the productivity, absenteeism, and healthcare cost for the organization as a whole. These impacts disproportionately affect marginalized workers like informal laborers, women in caregiving roles due to systematic inequality in workplace protections. So the objective of this review is to identify the cause of occupational stress, analyze effects on mental, physical, and organizations, evaluate stress reduction strategies at individual and organizational level. So due to lack of time, I'm skipping this review of literature. Directly coming to methodology. So the study selection process followed the PRISMA 2020 guidelines. The database used search includes Scopus, Gold Scholar, PubMed, and SiteInfo. The literature was searched with the following keywords: occupational stress, work stress, job stress, in conjunction with the causes, risk factor, consequences, impact, mitigation strategies, management, and interventions. A total of 840 causes were identified through database searches. And before screening, 176 duplicate records were removed, leaving 664 records for title and abstract screening. Out of these, 445 records were excluded based on their titles and abstract due to irrelevance. The remaining 219 full text reports were assessed for eligibility. 40 records were excluded due to the retrieval issue, and rest 159 after excluding 159 reports. Lastly, 20 studies will met the intake criteria and were included in this study. So for data synthesis, the review results were integrated and analyzed employing a narrative synthesis approach. Thematic analysis was used to extract primary themes on the causes, impacts, and management of stress in the workplace. So here's the finding of this review. The review identifies three major aspects of occupational stress: its root causes, its impact on employee health, and effective mitigation strategies. It synthesizes data from studies across sectors such as IT, healthcare, education, banking, and marketing. So there are primarily five sources of occupational stress identified across different industries and sectors. First one is the excessive workload. There are various studies that show that there is negative impact of excessive workload on well-being of employee, and it is very common and relevant in fast-growing sector like IT, healthcare, and education. Long working shifts hours, sharp deadlines, and pressure to achieve more milestone in limited time contribute in employees' burnout and mental stress. Second is our role ambiguity and conflict. Multiple job responsibilities with the numerous roles, conflicting demands, and lack of clarity in performance expectation are those factors which are directly contributors of mental stress, and these factors always result in the confusing environment, lack of satisfaction, and discontinuity in jobs. Third one factor is lack of control. Jobs in which autonomy is very limited, having no decision-making power, and other having influence over work process are always associated with the high level of stress, and this can be commonly seen in those organizations where hierarchical structures are very strict, and employees who do not have control over their work environment always face increased stress and the condition of burnout. Our next factor is work-life imbalance, the increasing overlap between professional and personal life, driven by factors such as remote work, dual income household, and constant connectivity, is a significant source of stress. This imbalance results in feeling of guilt, frustration, and difficulty in fully engaging with either work or personal life. The last one is our job insecurity. Sorry, the rising prevalence of job insecurity, influenced by the economic instability, organizational restructuring, and growth of a gig economy, contributing to the higher stress level. This is particularly evident in industries vulnerable to the economic downturns, and the fear of losing one's job lead to anxiety, depression, and both mental and physical problems. So, if you see that occupational stress also has very impact on its on the well-being of the individual or employees. So there are basically 4 domains. If you see, first one is the mental health. So, occupational stress is the major factor in the development of the mental health problems, anxiety, depression, burnout, and in severe cases, suicidal thoughts. The ongoing stress response can disturb the balance of neurochemicals in the brain, and resulting in the change in mood, sleep patterns, and cognitive functioning. Second is our emotional well-being. Persistent stress negatively impacts emotional stability, leading to the irritability, anger, mood swings, and strained relationship with others. This emotional strain is linked with, to the decreased job satisfaction, morale, and commitment to the organization. Next is our physical health. There are a few researches that confirm that chronic stress is related with the higher risk of developing various physical health conditions, including heart disease, hypertension, stroke, diabetes, obesity, and digestive problems. The last one is the behavioral outcomes. We see that occupational stress often lead to unhealthy coping behavior, such as substance abuse, use of alcohol, tobacco, and drugs, poor eating habits, lack of physical activity, and sleep disturbance. So these are the strategies for the mitigating occupational stress. These are on 2 levels: organizational and individual level. Let me start with the first with the organizational strategy. These are the actions that companies and institutions can take to create a healthier work environment. First is the idea of supportive work environment. This means fostering open communication, mutual respect, employees recognition, and promoting work-life balance. When organization prioritize these elements, it builds a sense of trust and reduces the pressure employees meeting. Our job design, when roles are clearly defined, workload are manageable, and employees are given autonomy, and stress level can drop significantly. It also helps when employees see opportunities for career development, and as it gives them a sense of purpose. Another is our employee engagement. Then there are flexible work options. If you go for individual strategies, it include one of the most recommended approaches is mindfulness and yoga. And this practice improves the self-awareness and emotional regulation. Another one is CBT, physical activity, social sport, time management and prioritization, balanced lifestyle choices. So this review highlighting the occupational stress is a complex, yet common issues across industries. While stresses vary, many of them share similar patterns like unclear roles, lack of support, and high workloads. The encouraging finding, though, is that solutions are within reach. On one hand, organization can reduce stress through better job design, engagement, and support system. On another hand, individual can take charge of their mental health by adopting strategies like mindfulness, physical activity, yoga, and better time management. I conclude this, in conclusion, occupational stress is a major challenge, but it can be addressed through proactive and well-rounded strategies. By combining organizational support with the individual responsibility, we can create a work environment that are both healthy and productive. This is not just about personal wellness; it's a strategic necessity in today's dynamic world. Thank you.
Thank you, Anil. I think you have taken 2-3 minutes more than stipulated time. So we will take a few questions if anyone have. Participants, anyone have any query, want to or anyone wants to contribute?
So we don't have enough questions. So I request Mr. Chetan Sharma for proceed his presentation. Mr. Chetan, I invite Mr. Chetan for proceed his presentation.
Good evening, sir. Sir, is my screen is visible to you?
Yes, yes. Go ahead.
Yes. Yeah, thank you for the opportunity, sir. Good evening, everyone. I'm Chetan Sharma, Psychiatric Social Worker, AIMS Rishikesh. Today, I'm going to present a study conducted as a part of the broader project, that is Project Naman, which is a pilot project currently being running in Munsiari and Belur Taluk of Uttarakhand and Karnataka state. So the title of my study is Understanding Student Mental Health Through a Teacher's Eyes, a North Indian Perspective. So as we know that the mental health issues among students have emerged as a significant concern globally, affecting their academic performances, emotional well-being, and social interactions. And schools are increasingly recognized as a key settings for addressing mental health issues among students. And a lot of researches has shown that teachers' understanding and responsiveness to mental health concerns can significantly influence students' academic and social outcomes. So, a study conducted in Kerala found that although teachers are often the first point of contact for students experiencing mental health issues, their ability to identify and respond effectively is limited due to inadequate training and lack of institutional support. The aim of this study was to explore teachers' insight into mental health issues among students with a focus on assessing teachers' awareness, capacity to provide mental health support, identifying existing challenges, and highlighting opportunities for improving mental health interventions in the schools. The methodology for this, we have conducted this study in 3 phases. The first one is preparatory stage. In that, we have had a discussion with the guide and prepared. We have prepared a discussion guide after a lot of reiterations and the training of the moderator. Participant recruiting through purposive sampling was done. And in the conduction phase, we collaborated with the block education officer and school administration. And thereafter, we conducted a total of 4 focused group discussions, 2 with the CBSE schools and 2 with the state board schools of Uttarakhand. And there was a presence of moderator and note taker. The data was audio recorded, and in the analysis part, we have like recordings were transcribed and translated back, and inductive live coding was also done. And thereafter, we gone through the thematic analysis. Regarding ethical considerations, the studies was approved from Institutional Ethical Committee of AIMS Rishikesh, and the participation was voluntarily and confidential, and that they can also withdraw at any stage. And the study was also compliant with the Declaration of Helsinki guidelines. So, coming to the results, the first thing which was emerged is the awareness and understanding of mental health needs. So during the discussion, we find that they just have understanding regarding the mental health, like if a person can handle the stress perfectly, we can say that it is a mentally healthy person, or like it is their awareness regarding the mental health. So these are 4 things, like cope with the challenges of life, peer pressures, family environment. So basically, they do not have a concrete knowledge about the mental health and what it is, but they just know about the symptoms and some kind of things regarding this. The second thing which was emerged is the current ways of management. So they highlighted that the students manage their current mental health issues through peer support, using of social media, that can be a negative thing also, substance use also there, and the physical activity was also there. So in the next theme, they have highlighted the promoting mental well-being in the classroom. So they mentioned that we can integrate mental health in the curriculum so that students can get benefit from that, and they're also like creating a safe space for the students. In the next theme, like barriers in seeking mental health support, the first one is the stigma. Thereafter, the insufficient training of the teachers so that they are unable to uh, identify the proper students that those who have mental health issues, and the parental resistance and time constraints were also there. In the collaborating with parents and community, they mentioned that the inclusion of traditional ways or practices, like through these ways we can collaborate with the community and can create awareness among the masses. And regarding the training, like how we can train them, they highlighted that if we want to train the teachers, there should be a practical based training. The theoretical aspect in that training should be a minimum, and there should be some kind of classroom based intervention should be taught to the teachers. And in the last theme, the concern specific for teachers, like they mentioned, there was a poor work-life balance for the teachers. There was financial instability and the limited career growth of these. So all these issues also impact their behavior and the student-teacher relationship also. So coming to the discussion, the findings from this study provide a comprehensive understanding of the teachers' awareness, perceptions, and practices related to student mental health in the North India. And as we can see that the teachers' awareness is often limited to surface level symptoms such as sadness, anger, rather than the deeper mental health concerns. And this finding aligned with the research conducted in Eastern China by Yao et al., which reported that the teachers struggle to distinguish between typical adolescent behavior and signs of mental health issues were there. And also, teachers reported employing informal coping strategy to help students manage mental health concerns. And these strategies, including encouraging peer support, facilitating open conversation, providing academic adjustment, which align with the findings from conducted a study conducted by the Parikh et al. Also. However, teachers admitted feeling inadequately prepared to handle complex cases and often lacked confidence in implementing structured mental health interventions. Uh, a critical barrier identified was the absence of structured mental health resources within school, including the lack of dedicated mental health professionals, and which is consistent with the findings from Fatima and Tonto, where teachers prefer to offer informal support rather than to seek the professional help, primarily due to social stigma and perceived lack of professional resources also. The limitation of the study is like this sample was limited to teachers from a specific geographic region, which may affect the generalizability of the findings. And additionally, the study relied on self-reported data, which may introduce report of bias. And despite these limitations, the study provided valuable insight into the challenges faced by teachers and offer practical recommendation for improving mental health support. Further research should explore similar themes across different educational settings and cultural contexts to develop a more comprehensive understanding of teachers' role in promoting mental health in schools. So, concluding this, the finding revealed that while teachers possess a basic understanding of mental health issue, and there is a high workload, lack of institutional support, and parental resistance, further constrain their ability to provide effective mental health care. So, we need to work in this area also. And the study further highlights the need for comprehensive mental health training program for teachers, focusing on early identification, intervention strategies, and referral pathways also. So I acknowledge the block education officer of Munsiari and the school administration and all the participants and my fellow investigators also. So thank you, sir.
Thank you,
So these are
Chetan.
some snippets.
Well presented. You have finished in time. So it will be difficult for those who are present to recall what others have presented if we take the questions after the session. So I would like to invite participants, if anyone have any query, can raise. Maybe few questions we can take. Otherwise, I would like to invite, if no one have any queries, or next presentee.
Mona Lisa Sahu. I invite Mona Lisa Sahu for proceed her presentation, sustainable development through the lens of Indian spiritual philosophy, a systemic review. So please, Mona Lisa.
Yes, sir.
Yeah, please.
Thank you, sir, giving me an opportunity, and very good afternoon to everyone. My name is Mona Lisa Saho, and recently completed MPhil in Psychiatric Social Work at SCB Medical College and Hospital. And now I am working as a faculty of the Department of Social Work at M. Rampur, Kalahandi. And today's my research topic is sustainable development through the lens of Indian spiritual philosophy, a systematic review. So these are the content of my presentation. Sustainable development defined as meeting the present needs without compromising the futures involves environmental, social, and economic balance. However, focusing on policy and technology may neglect the ethical and spiritual value guiding human behavior. In Indian spiritual philosophy rooted in Bhagavad Gita, the Upanishad, and the Swami Vivekananda teaching principle like Dharma, Ahimsa, and Aparigraha, promoting harmony with natural and social responsibility. This review examine now this spiritual insight support sustainability and psychological well-being. The objective of the study to systematically review literature that explore how the teaching of Bhagavad Gita, Upanishad, and Swami Vivekananda contribute to sustainable development and psychological well-being. Methodology type of study, systematic review, data source, academic database, Google Scholar, Gestor, ResearchGate, and systematic semantic scholar. Analysis methods, qualitative thematic analysis process, article selection and screening, repeated reading and coding, identification of key themes. Sort strategy, a comprehensive literature search was conducted using the database. The search covered from January 2000 to March 2025. These are the key terms that I searched in Bhagavad Gita and sustainability, etc. Inclusion criteria written in English, published between 2000 and 2025, focused on Bhagavad Gita, Upanishad, or Swami Vivekananda teaching in the context of sustainability, environment, ethics, or mental well-being. Study that draw connection between spiritual value and sustainable development or psychological resilience. Exclusion criteria, article not published in English, publication before 2000, article that mentions spiritual text but without link them to development, sustainable or mental well-being. Selection process, initial search 137 source after removing duplicate and screening title and abstract based on the inclusion and exclusion criteria. The 42 articles were shortlisted for the full text review. Following a thorough assessment, 18 studies were finalized, selected a thematic analysis. The preferred reporting item systematic review prisma flow diagram was followed to ensure transparency and responsibility in the selection process. Here the prisma flow diagram, the total selection of the topic qualitative for synthesis in number of 18. These are the summary including studies. Thematic analysis. The thematic analysis revealed three key insights like first theme inspired by Bhagavad Gita, emphasize selfless action through karma yoga, performing one duty without attachment to rewards. Then second themes, Upanishad highlight the interconnectedness of all life and promote simplicity. It encourages self-awareness, simple living, and ecological harmony. The third theme, based on the teaching of Swami Vivekananda, follow on service and character development, like seva or selfless service is viewed as the highest form ownership. The result, the systematic review of 18 study revealed three core themes linking Indian spiritual philosophy with sustainable development, selflessness action, Bhagavad Gita, unity and simplicity, Upanishad, and service and character, Swami Vivekananda, Karma Yoga. Promotes ethical leadership and psychological balance. The Upanishad encourage interconnectedness and minimalism and mental well-being, and Vivekananda teaching highlight service, education, and inner strength for inclusive growth. Together, these findings show that Indian spiritual thought supports sustainability and holistic development. Discussion the among the discussion finding was of the found Sarma 2013 and Singh Verma in 2019 argued the Karma Yoga encourages moral leadership and responsible living. Sukla and Rao 2014 showing how spirituality contribute to friendly attitude and psychological clarity. Ghost 2015 and Rajendran 2022 findings shows that inner strength and spiritual leadership are crucial for sustainable development, sustainable social progress. So limitation of this study, only English language study 2000 to 2025 are reviewed. Most studies were theoretical, few estimate real world application, and focus limited to Gita, Upanishad, and Vivekananda, excluding other philosophical like Jainism, Buddhism, and Sikhism. Implication, spiritual teaching promote ethical living, mental well-being, and social responsibility can be integrated to policy, education, leadership training, and environmental program. Value-based education can build socially conscious and mentally resilient individual. Mental health professional can use spiritual tools for currently sensitive therapy. Policy can be ethically grounded and environmentally aware. The future directions are need for quantitative study on a real world application of spiritual practice, takes intervention based on Gita, Upanishad, and Vivekananda teaching, including regional language study and rural perspectives, encourage interdisciplinary research across philosophy, psychology, and environment and social work. The conclusion, Indian spiritual philosophy as reflected in Bhagavad Gita, the Upanishad, and the teaching of Swami Vivekananda offer a holistic framework for sustainable development and psychological well-being. The values selfless action, unity, and service promote ethical living, environmental care, and social responsibility. This review shows that this teaching supports sustainable practice at both individual and societal level. These are the references. Thank you.
So anyone have any queries? We can take few. Presentee is here. If not, who is the next presentee?
Next presentee is Manish Prasad. Now I invite Mr. Manish Prasad for proceed his presentations.
After this, there will be how many more presentation, Pradeep ji?
Last, this one is the last presentations.
Okay, okay.
So, Mr. Anil, Mr. Manish Prasad.
Manish is not there in the participant list, so I think he either he left or he had some. Manish, are you there? No.
Pradeep ji.
So now the session is start for question answers. If any audience have any questions, any doubt, any clarification, any contributions, they can produce without any hesitation.
I think by the time queries or contribution comes, Pradeep ji, you can comment on their presentation. You start with.
Yes, if no further presentation, then we will conclude the sessions. So regarding first presentation, yes.
Sir, if I may be, I just intend to comment on the two presentations.
Yes, yes, sure.
One, Chetan's presentation, I must say that it was well organized, well structured, study, presentation, everything. So Chetan, it
Good.
was wonderful. I might be biased. He was my student, but I found it was wonderful. And
Thank you, sir. Thanks a lot, sir.
second, just one comment about Mona Lisa's presentation. While talking about inclusion, although that you was also within the time frame and your structure was also good, but while coming to the inclusion and exclusion criteria, you just negatively phrases the words. For example, for inclusion, you included studies between this year to this year, and for exclusion, the studies those who are not in that year. Uh, inclusion in English and then exclusion not in English. So such kind of negative phrasing should not be used for designing inclusion and exclusion criteria. Thank you, chairpersons. That's it from my side.
Thank you. Uh, so the final comments is from my side is the last presenter Mona Lisa Sahu. Your title is very nice, but content is so many content is missing. Your topic is so vast, Indian spiritual philosophy. So it could be better if you add uh, Vedic philosophy like Rajogun, Tapogun type presentation you should mention. And one important thing is already missing if you talk about Indian spiritual philosophy like Atm Gyan. So now in current scenario, you are focusing on thought and behavior, cognitive behavior therapy. So Atmagyan and Maya, you should present your presentation should be add such kind of concept. What is Maya and what is self gyan? So that has it could be better if you add such kind of material in your presentation also. Another presentee is Chetan. Chetan is really present a very well presentations, and he cover within the time. And practically this is very important titles of how we can improve the positive mental health of the student as well as teachers. So if students are in stress, so teacher are also responsible for this. So we should evaluate the mental states of the teachers, and teachers should be sound health and sound positively. He should be healthy, mentally sound. That's why he or she can be provide a better he can be better support from the students also. So now the another presenter is Anil Kumar. He presented very well regarding occupational stress. So it's a very important topic. Occupational stress create suicides, create substance abuse and many stress related problems. So he explained very nicely about the what is the causative factor, what is the protective factors. So on Kumaran, his title, he's a first presenter. He present very well, but he has mentioned about faith and practice, a comparative analysis of Christian. But he didn't mention what is a comparative analysis. He did not cover the comparison between another religion. That is a missing parts. And it's true that the Indian social work professional social work has been initiated by USA and UK, cost and settlement house movement. It's true, but in current scenario, what is the practical implication of this paper? Now we are focusing on Indianization of social work and add MBSR and yoga, meditations, so many things we are covered. So it could be better if you add if you your presentation should be a start from Christianity and end from the Indian aspects. So thank you each and everyone, and thank you so much Dr. Bhupendra and Dr. Indrajit.
Uh, Thank you. I would like to share my observations. Like Mona Lisa, I think you have focused on karma yoga. Like in Indian philosophy, we have. You can you name Mona Lisa?
Yes, sir.
What are
Yes, sir.
other?
Sir, Karma Yoga and Vivekananda's philosophy,
No,
Vivekananda's
no.
thought
Karma.
and
Basically,
system.
Vivekananda have written all the yoga. Like, do you know the names? What are those? Karma yoga, bhakti yoga, Gyan Marg, Gyan Yoga. Okay.
Yes, sir. Yes, sir.
So you have focused basically, Vivekananda showed with his life mainly the Karma Yoga. So your paper was basically focusing on that. So it was okay, but for implication, but you have raised it in your limitation also. The main thing, how we can implement those things, the Karma Yoga, in our practice of social work. Okay.
So, Dr. The title
And
is very nice, but content is missing. So many content are missing in her presentation. So it could
Sir,
be that
actually, I
if
focus
we
on
add,
only
your title is very nice, but you are missing so many content. So in future presentation, your content should be strong.
yes,
Like
sir.
Dr. Indrijit had mentioned about that. Dr. Swami Vivekanand has mentioned so many techniques, so many types of yoga. So you should at least mention about that also.
Okay, sir.
another presentee, I missing the name, like the one who presented for this one, teachers to study. Who? What is the name?
Chetan.
Yes, Chetan.
Chetan.
Chetan. Yeah. Methodology was sound. Your methodology was sound, but maybe in objective you have tried. From it is my view that you have tried to include many things with that limited participants, limited number of your sample size. That may be a difficult task. You may comment on that, like what you have included, the prospect teachers, what the teachers view regarding children's problem. At the same time, you have included the teachers, what they themselves are facing problem. So many of themes with this limited sample may be difficult. You can comment on that. uh, Chetan, are you here?
Yes, sir, I was unable to hear the question due to network issue, sir. Sorry.
Hello.
Hello, Sarji.
Chetan sir is asking that why means you commented on a small sample, very small sample, and you concluded a lot of things. So would you like to comment on it?
Basically, basically, data saturation happened when you have studied. It was a qualitative
Yes,
one.
sir.
So, whether
Yes.
that data was saturated, because you
Yes,
have
sir.
tried
Sir,
to
like we have
include many
conducted.
themes. Okay, that is my observation.
Yes, sir.
You can comment on.
Thank you, sir. Thank you, sir, for the question. Yes, sir. Like we have in the initial phase, we have conducted a focused group discussion with two schools. In that, we have 10 participants each, and thereafter, like till that, we haven't reached to the saturation in those focused group discussion. So we have conducted two more focused group discussion in that, and thereafter we reached to the saturation. And a total of participant in all the four FGDs were around, sir, 45 participants were there. So yes, sir, we reached to the saturation. That's why we didn't conduct further FGDs in this area.
Okay. That was my observation, that maybe your data saturated by. I am. My suggestion will be go with limited objective, but because if you have, when you have so many dynamics, so the study, the findings, explaining the findings, at times it becomes difficult. Otherwise, I'm happy. Methodology was okay. It was, and same for the first presentee also. So with this, if no one have anything to say, I would like to conclude the session, and over to Dr. Pradeep ji.
Thank you, Dr. Indrajit. I have covered all the things. So I hand over the mic to the chairperson, Dr. Bhupendra.
Okay.
Please conclude the session.
Okay. Thank you all. Thank you.
Thank
Dr.
you,
Bhupendra.
all the presentees, and thank you both the chairpersons for being with us. Although we are running behind the schedule and you have to wait along, but you waited and you are with us. Thank you so much. So, without any further delay, again, I have to apologize for a long delay and would move to another session. That is our free paper session G. And for this session, we have two different chairpersons. One is Dr. Satabdi Chakravarti. Ma'am, you are with us? Satabdi ma'am? Chetan sir? Dr. Chetan?
Yes, I'm here.
Okay. So Satabdi ma'am was also here, but I think either she get disconnected or she might have some obligations
Yeah.
because of the delay. So without any further delay, Chetan sir is our today's chairperson. Another chairperson is Dr. Satabdi Chakravarti. Ma'am is additional professor in the Department of Psychiatric Social Work at IBHAS, and Chetan sir is faculty in Karve Institute of Social Sciences, and they both would handle the further sessions. So without any interruption, I would request Chetan sir to lead because ma'am is right now not with us. So Chetan sir, over to you.
Yes. Yes. Very good evening, all of you. All the presenters are welcome in again in the ISPSW conference paper presentations. I would like to thank you, our Honorable Secretary of ISPSW, Professor Dr. Bhupendra Singh sir. And without wasting time, I think I heard last session as well. There are delays into sessions. Without wasting much time, I would like to start the session. So welcome all the presenters and kindly stick to the theme. I think time has already given. You will have to stick to the time, and then we'll have question answer sessions and contributions at the last of the session. So meanwhile, I will be interrupting the presenters. Is that okay, Bhupendra sir?
Yes, sir.
Okay. Yeah.
Sir.
So first presenter, kindly start your presentation. Who is there?
Aparajita.
Aparajita. Yes.
Yes,
Please.
sir. Yes, sir.
I would like to read. Just a minute. Sir. Can you please read the name of your paper?
Yes, sir. With your permission, can I present my slide or share my slide?
Yeah. You can start with your presentation. No problem. Just read the name of the paper.
Is it visible, sir?
Yeah. So, yeah. Aparajita, just a minute. So, we are going to start with the synthesizing the evidence and umbrella review on the effectiveness of yoga therapy for anxiety disorders. Okay.
Yes, sir.
Yeah.
Sir,
So,
my...
Aparajita is going to present. Yeah. Welcome, Aparajita. Kindly start.
Thank you, sir. Sir, is my slider moving?
Yes.
Okay. Thank you, sir. First of all, good evening to all of you, and thanks to ISPSW to giving me opportunity for the present my paper. I am Apraita Barik from SCB Mental Health Institute, SCB Medical College and Hospital, Cuttack, Odisha, and my co-author is Guru Prasad Bag. He is also from my institute. So my topic is synthesizing the evidence and umbrella review on the effectiveness of yoga therapy for anxiety disorders. These are my contents. Introduction. Anxiety disorders are among the most prevalent mental health conditions worldwide, often resulting in significant emotional, social, economic burdens. As conventional treatments such as pharmacotherapy and cognitive behavioral therapy are universally effective or accessible, there is growing interest in complementary approaches like yoga therapy. Yoga, integrating physical postures, breathing techniques, and meditation, has been increasingly explored for its potential to alleviate symptoms of anxiety. Given the expanding body of literature and multiple systematic reviews on the topic, an umbrella review synthesizing evidence from existing systematic reviews and meta-analysis offers a comprehensive assessment of yoga therapy's effectiveness. This study aims to evaluate the quality, consistency, and strength of evidence supporting yoga therapy as a treatment modality for anxiety disorders. Then the objective of this umbrella review is to systematically synthesize and evaluate the existing evidence from published systematic reviews and meta-analysis on the effectiveness of yoga therapy in regarding symptoms of anxiety disorders. This review aims to assess the consistency and strength of the evidence, identify gaps in the literature, and provide comprehensive insight to inform clinical practice and future research. Then coming to methodology, this umbrella review, also referred to as a systematic review of systematics reviews or a meta-analysis of meta-analysis, was conducted to evaluate the effectiveness of yoga therapy for anxiety disorders. Search strategy, a comprehensive literature search was independently conducted by both authors in April 2025 using 3 electronic databases like PubMed, EBSCO, and Science Direct. The research aimed to identify identify all relevant studies published in peer-reviewed English language journals between the years 2000 and 2025. Inclusion and exclusion criteria. Studies were included if they met the following criteria like systematic reviews or meta-analysis evaluating the impact of yoga therapy on anxiety disorders and published in peer-reviewed journals written in English and included clinical or observational data on individuals diagnosed with any form of anxiety disorder. Studies were excluded if they focused solely on stress or general mental health without specific reference to anxiety disorders, where narrative reviews, protocols, or theoretical papers did not involve yoga as a primary intervention. These are my Boolean operators which we were used for our research. In Prisma chart, so identifications in identification databases, PubMed, that is 254 data, and Science Direct, that is 672, and Abesco, that is 0. So total data from both databases like 296, and records removed before screening, duplicate records removed, that is 37. And in screening, records screened total is 889, and books and books chapters, that is 13, and thesis digitation, that is 2 number, and primary studies, that is 573. Reports out for retrieval, that is 301. Reports could not retrieved, that is 8. Reports accessed for eligibility, 293, and reports excluded different objective, that is 204 number. And non-experimental studies, that is 78 number of non-experimental studies were excluded. Then included studies, that is 11 number. These are my included studies with respective of title, author, journal, year, and methodologies. Findings, consistent evidence for anxiety reduction, multiple meta-analysis and systematic review demonstrate a small to moderate short-term reduction in anxiety symptoms following yoga intervention compared to control or non-treatment groups. These effects are observed in both general population with elevated anxiety in those with clinical diagnosis, although effects tend to be more pronounced in non-clinical or undiagnosed groups. Then second one is comorbid symptom improvement. Several studies report positive secondary effects on depression and sleep quality, especially in population with comorbid depression, chronic illnesses like cancer, rheumatic diseases. Yoga was found to significantly improve mental health outcomes in pregnant women and cancer patients, indicating broader applicability. Then third one is population variability and heterogeneity. There is substantial heterogeneity across studies in terms of participant demographics, children, adolescent, adults, clinical, non-clinical. Groups like type of yoga and outcome measurement tools. Effects tend to vary depending on interventions, intensity, setting, participant characteristics. And then fourth one is methodological limitations, and fifth one is safety and feasibility. Then conclusion, this umbrella review synthesized findings from 11 high-level systematic reviews and meta-analysis, providing cumulative evidence that yoga therapy is an effective and safe complementary intervention for reducing anxiety symptoms. The reviewed literature also suggests beneficial secondary effects on depression and sleep quality, particularly in population with comorbid conditions such as cancer, pregnancy-related mental health issues, and chronic illness. Despite these positive outcomes, the overall certainty of evidence remains limited due to methodological shortcomings, heterogeneity in interventions, and variability in study populations. Therefore, while yoga shows therapeutic promise, further high-quality standardized research is essential to establish clearer clinical guidelines and ensure replicability across diverse settings. Implications: yoga can be integrated as a complementary treatment in mental health care setting to support conventional interventions like CBT and pharmacotherapy, particularly for individuals seeking holistic or non-pharmacological options. These are my references. Thank you.
Good, Aparajita. I think you have presented in a time. You were able to present into time. Okay. Is there any question from the floor? We will take 2-3 questions, then we'll proceed for the next session. Any question, any contribution from the floor?
None.
Am I audible?
Yes, you are.
Yeah. Yes, floor. Any question for Aparajita? regarding a methodology, regarding contribution and all? Conclusions?
No comment, sir.
Okay, no
Please.
comment, no problem. I think I will have to then comment within
Yes,
few
yes.
seconds, and I will proceed. I think this was really the need of the hour, and whatever conclusions you have created through the meta-analysis of the meta-analysis, I think this is what is required. And both I think there is another co-author as well for your paper. So the findings, as far as finding concern, I think we need to again revisit, whatever the earlier findings were there. That I think we would like to just again, we would have to add a few more reviews. Okay.
Okay, sir.
And is there any practical study? Because once you are, touching to the meta-analysis, you will have to find out, is there any other study conducted directly with the primary data? Okay. If there is any, then you will have to search it out. Then I think we will have to get more results on
More, yes, sir. Okay.
that. Okay. And more clarity. Yes.
Yes, sir.
Perfect. So I think regarding the topic and the findings, it is really helpful for the those who are entering into this field. And whatever I think you have suggested cognitive therapy as well.
Yes, sir.
It is impactful. Yeah.
Yes, sir.
So I think, yeah, once we are talking about the yoga, transcend medicines, and few other techniques which were there, existing at the ancient era, I think all these practices were much useful. We need to connect it into, again, reconnect into field of psychiatric social work. You touched that. Good. Thank you for, choosing this subject and doing good. Yeah. Good.
Okay,
Yeah.
sir.
You want to
Thank
say
you, sir.
something?
No, sir. No, sir. I will practice in future for my studies, sir.
Yeah,
These points. Yes.
Yes, good. Okay. Yeah.
Thank you.
So moving forward, I think I would like to invite Ninum Grace. Sorry, I'm unable to.
Grace County, sir.
Name Grace County. Okay. Yes, sorry. And you are going to present faith-based engagement of perinatal mental health promotion in tribal communities. Again, I think this is going to be an interesting study. I would like to request Ms. Kaute to kindly proceed with her presentation.
Thank you, sir.
Yeah.
Is my slide visible?
Yeah, it's visible. Yeah.
A very good afternoon to all. My name is Name Grace Kaute. I'm from Manipur and a PhD scholar under the Department of Social Work, IGNTU. So I'm going to be presenting on the conceptual paper titled Faith-Based Engagement for Perinatal Mental Health Promotion, a conceptual framework for psychiatric social work practice in tribal communities of Manipur. I will move to the introduction straight away. These are the authors.
I think you just keep the introduction.
This is the introduction, sir. Is it visible?
You can skip it. Yeah.
Okay. So the perinatal period is a time which starts from the time of pregnancy to the postpartum phase, where there are significant changes in the physiological, psychological, and social aspects. And in this period, women are considered to be vulnerable when it comes to their mental health. So, in spite of being vulnerable when it comes to mental health, are often overlooked in the reproductive mental health domain. And a significant percentage of Indian women experience some form of perinatal distress, but it is found that from studies, only few are receiving help. So a study was conducted by Subraja et al., where it was found that an estimation of 1 in 5 women encounter mental health struggles during this period, out of which 7.6% of women reported of self-harm. So despite its importance, it remains unaddressed and unrecognized, mostly in most states of India, especially in the northeastern states of India and Manipur. So if you look at the map here, this is the map of Northeast, and the portion which is encircled in red is the state of Manipur. And the state of Manipur here is divided into the valley region and the hilly region, where the valley region is where the hilly regions are mostly occupied by the tribal population. And these hilly regions has many barriers in terms of the systemic barriers, such as the political exclusion, socio-economic disparities, lack of resources and infrastructures in terms of health and education. So because of these barriers, there are number one, one is stigma related to mental health issues. So women, even if they have mental health issues, they are often reluctant to talk about their emotional problems, fearing that they will be seen as weak or someone who is unstable. Secondly, there is lack of mental health literacy when it comes to perinatal mental health and mental health at large. And also, third is that the tribal regions lack sufficient mental health infrastructures and also even health infrastructure also. And fourthly, even access to basic antenatal care is very, very inadequate in these tribal regions. Coming to the problem statement, four problem statements has been highlighted here. The first one is the existing maternal mental health strategies are mostly biomedical and urban centric. So these services available are mostly in the urban setting. So making them inaccessible to tribal women living in the rural areas or rural communities. And for instance, in the city that is in Imphal, there are many psychiatrists, there are many maternal health clinics and even counselors. But when it comes to the tribal population, these facilities, even basic facilities, are very lacking. Sorry. Second is the clinical approaches do not account for cultural beliefs, traditional healing practices, or the spiritual worldview. Tribal communities, because many tribal women interpret their emotional distress through spiritual or social lenses. Thirdly, there is also a disconnect between community practices and formal mental health systems, since most of them are located in the valley region, which is mentioned. So the tribal communities, mostly when they have this emotional distress or mental health issues, they mostly turn to the faith leaders, elders, or traditional healers to asking them to come and pray for them. And because of all these systemic barriers, even when they have emotional issues, mental health issues, they do not come up or speak up for seeking professional help. So this gap calls for the new models that are deeply rooted in the community's social and spiritual life. So the aim of the paper here is to propose a faith-based, culturally grounded model of psychiatric social work practice. And this model utilizes existing faith structures such as churches and local religious leaders to spread awareness about mental health problems and also address stigma related to it, facilitate early help seeking, and also deliver specific context-specific psychosocial support to perinatal women. And this conceptual framework is based on three key principles. Number one is community mental health principles, which emphasizes on accessibility, participation, and decentralization. Number two, it focuses on indigenous knowledge systems, including the traditional healing practices and spiritual explanations of illness. Number three, it focuses on spirituality, that is, which is central to tribal identity and community resilience, which is also their strength. So this framework sees the church or the religious body, and I mean the churches not just as a religious body, but also as a potential partner in health promotion, especially when it comes to something which is culturally sensitive as mental health. So what can faith-based communities do in such population? Here, the tribal communities, faith-based communities, such as the clergy or the churches, play a moral authority, and they are mostly the first responders in times of distress. So they are mostly trusted by the community members. So these can be used to the advantage to orchestrate the awareness on mental health, focusing on reducing stigma, normalizing mental health conversations in church services or even the women fellowship programs also, and also make referrals to referrals of the perinatal mental health problems to professionals when required. So by including all these areas into the mental health promotion, we are not just introducing something which is foreign, but we are trying to amplify existing structures that are already existing to support the tribal women. So as a psychiatric social worker, we can also serve as a cultural mediators by bridging traditional beliefs and modern mental health care practices. We can also work as an advocate to educate communities on perinatal mental health by collaborating with the churches, with the clergy, the pastors who are already trusted by the community members, so that they can help, they can conduct mental health literacy campaigns. We can, and counselors can also be trained, and then referrals can be made. So the proposed intervention is that we can focus on the church-based psychoeducation mental
Guys,
health.
please conclude. You exceeded your time limit.
Okay, sir. Just last, we can propose to a church-based psychoeducation mental health, and then spiritual integration, which trauma-informed care, and then faith-based pathways to referral care to professional care, and then day counseling training for clergy. So lastly, this framework offers triple advantage. One is promotion of mental health literacy. Second is enable text-specific support. And the third is build on existing trusted institutions towards decentralization of inclusive systems, positioning on healthcare systems with tribal community cultural values. So I'll just stop from here. So these are the references.
Chetan sir. Okay, Grace. Probably some technical issue with another chairperson as well. So I must say that your focus was, most of the focus was on the introductory part. That can be shifted towards your findings and the recommendation part. That would have make more effective your presentation. But it was a good presentation. Keep doing. Thank you. All the best. May I request the next one? Kassis Bachchan, are you with us?
Yes, sir. And
Please go ahead.
yes, sir. Sir, can I share
Kassis,
my
keep in
screen?
the mind, once you will hear the sound,
Yes,
that
sir.
means you have to stop now, right?
Okay, sir.
Please. Not this one, the next one.
Yes, sir.
Okay, please start.
Yes. So is my voice and my slide audible and visible?
Your voice is bit slow, but slides are visible.
Okay. Okay. So very good evening to respected chairperson and the other delegates. My name is Kashish Bachchan and I am a PG student from Department of Psychology, Magan Mahila College.
Very sorry. Actually, what happened? There was internet correction.
Bhupendra sir, you handle it, na? Bhupendra sir.
Kassis, please continue.
Okay.
Kassis.
So my
Yeah.
You will
topic
talk.
is exploring possible influence of music among contemporary youth. So if we talk about music, so music is something that intrigues every age group of individual, whether it's an infant who is first time listening to his mother or her mother's lullaby, or an age group who listens to music in the form of entertainment or through religious songs and anything like that. So if we give music a very if we give the definition of music in a very layman term, then we can say that music is the arrangement of sounds to express form, harmony, melody, and rhythm. So music plays a very essential role in rituals, celebration, and cultural activities. And at the same time, it influences our emotion, behavior, and has application in media, education, and healthcare.
and it even have a lot multidisciplinary access. As in psychology, we studied it in the form of a therapy, which helps us in anxiety and stress. Uh, if you talk about its origin, so its origin is debated. But in Indian context, if we talk about the Indian music, Indian classical music, which arrives from the Vedas, uh, and if we talk about different, it has various elements. Next, we come to the review of literature. There are a lot of studies done on music and its influence, but majority of the literature that I have studied for this uh, research was based on American or the European people, but very less or very counted studies are done on Indian context. Coming to the rationale, my objective was the music and the brain. That is, music profoundly influences emotion, cognition, memory learning, and behavior. Research explores its neurological and psychological impacts. At the same time, it has its therapeutic benefits, cultural and social impact. And my main focus of this study was on its how music affects youth, that is supporting mood regulation, stress management, creativity, and productivity, especially in the underexplored Indian context with non-experimental data. Next, coming to the methodology, my objectives were how to investigate how various types of music influence the mood, how explore intersections of music and youth's lives, understand how music affects daily life and generates relaxation, and examine music's role in shaping life experiences, and investigate how individuals use music to escape reality. Now, the participants, I have actually followed the WHO's youth definition, which described 15 to 29 years of individual, but my study was majorly focused on 18 to 28 age of individuals. It was selected through purposive sampling, and only English profession participants within the age range were included in it. And the tools and techniques that I used, in this specific area, there were not many scales. So me and my guide, we constructed this survey, which included 31 questions. At the same time, it has informed consent, social demographic sheets, and it was distributed via Google Forms, through social media, and emails. These were some of the questions that I asked. It included, how does music influence our life, or how do they play any kind of music or lullabies while they are sleeping, or if they think music stimulates creativity, or if they listen to music while studying, whether it improves their grades or not, or do they prefer listening to music while long drive or while driving, or is there any specific music that bring back a specific memory, or is music influencing the societal norms, or is there any specific music that is very meaningful for them, or if they concentrate on anything while listening to music, or if it is a medium for communication of their feelings. And at last, I asked them if there is any benefits of music in their life because of music. So coming to the findings, we found that widespread influence of music, like 84.9% of participants reported music significantly impacts their lives, citing benefits like mood evaluation, emotional support, and personality shaping. They even showed emotional, cognitive, and creative effects, like music can stimulate creativity. Situational use of music. Many youths prefer music during specific activities like driving, sleeping, and some even during study. Sorry. And the music and society, like a majority believe that music influences societal norms behavior, and values. And the main highlight was music is a crucial role in a youth lifestyle as a tool for motivation, emotional regulation, stress management, and self-expression. In conclusion, I would say that music had an emotional impact, creative, motivational tool. It was a coping mechanism that music served as an escape from reality, helping them manage their stress and emotional challenges. While most of them was very positive, some participants noted that music can be a distraction, especially in academic settings, and overall music is perceived as a powerful remedy for soul, contributing to emotional and psychological well-being. These were some of the implications of my studies, that this study can help exploring psychological issues that can be reduced or relaxed by the use of music. It can even offer a good direction for further researchers, as we have very limited research in this area in Indian context. Furthermore, this is a research can be done on comparison between different age group for more clarity, which I was not able to do. And these were some limitations. Thank you. This was my
Sir, you are
presentation.
mute. Chetan sir, unmute yourself.
Sorry, I was unable to, connect because there are some issues related to connectivity here. It's heavy raining, and due to that, I could not understand what exactly methodology used by you here. What is the tool?
So the tool, actually we developed that tool with my I developed it with my guide. It had 31 questions in two sections. The first section included the consumption pattern, how the youth consume music, and the second part had the influence, like how they are influenced with music. So it has 31 questions, which included the consent form and the
That I
social
saw, that
demographics.
I understood. I really
Yes, sir.
appreciate the efforts taken by you. But
Yes, sir.
first of all, I would like to just mention here, whenever
Yes,
you
sir.
are developing some scale, I think we need
Yes,
to
sir.
check the reliability, validity. These things matters actually.
Yes, sir.
So
Yes,
if
sir.
there are some skills that can be used, that is the first thing.
Yes.
Second thing, which is more related to your topic, is music. So what kind of exactly music is impacting, and on which mental health condition or mental condition the music is impacting? I think that needs to be separated properly. It
Yes,
should
sir.
be differentiated. Otherwise, what happens now? You just mentioned that elevation of mood and all. So I think
Yes,
it
sir.
is useful for the people those who are suffering from sadness, depression, something. But what about the person who is into already mania? That is the condition. Okay.
Yes,
So
sir.
is there any tool, is there any questionnaire or question to be used to reduce that particular manic stage of that particular person? So I think this is debatable. I'm not going to demotivate you, but
Yes, sir.
ultimately these things needs to be taken care of. Okay.
Yes,
And
yes, sir.
keep in mind that there is always reliability, then validity, it should be taken care of. Okay.
Yes, sir. Definitely,
And
sir.
whenever you are conducting these kinds of studies, no doubt there are some reviews, but we'll have to understand how the reviews also reveals, okay, what kind of results are there. Okay.
Yes, sir.
Yeah,
Definitely,
Bhupendra,
sir.
and any other participant, is there any question? Uh,
Sir,
to her?
unfortunately, time is not permitting much, so I just request you to proceed.
Okay.
Tanaya has already presented in award category, so she is not going to present. Kassis has already present. Now you can call Chandu Ram
Thank you,
Bhau
sir.
Patil.
Thank you, sir, for the opportunity.
Yeah, I
Good
have some
evening, sir.
comments for last participant, but I think, comment into the last, not now. Yeah.
Please.
Yes, next participant, please. Yeah, please
Good morning,
proceed
sir.
your presentation. Yeah.
मैं डॉक्टर चंदू पाटिल, आठवले समाज कार्य महाविद्यालय भंडारा, महाराष्ट्र से हूँ। मेरा विषय है गरीबी निर्मूलन में बचत गट की भूमिका। तो मेरा जो टॉपिक है, तो मैंने सावनेर, नागपुर डिस्ट्रिक्ट में सावनेर तालुका के जो भी सेल्फ हेल्प ग्रुप है, इनका व्यू अकॉर्डिंग टू गरीबी निर्मूलन, तर इसके लिए मैंने सावनेर तालुका में जो भी बचत गट है 5,793 बचत गट है, उनके अध्यक्ष के स्टडी के लिए लिया गया टोटल पॉपुलेशन है। तो मेरा खास उद्देश्य ये था कि दारिद्र्य निर्मूलन में बचत गट का योगदान क्या है, ये जानना था। और हर तरफ देखा जाए तो अभी भारत में 2030 तक जो गवर्नमेंट का टारगेट है कि विकास के लक्ष्य का टारगेट पूरा करना है, तो गरीबी निर्मूलन ये बहुत ही महत्वपूर्ण मुद्दा है। और तो इसके चलते मैंने टोटल पॉपुलेशन में से 361 रिस्पोंडेंट रिसर्च मेथोडोलॉजी के अंतर्गत ली गए। यहाँ प्रोबेबल में से रेगुलर मार्किंग मेथड से मैंने 361 रिस्पोंडेंट लिए, उनके माध्यम से डेटा कलेक्ट करके जो आज की स्थिति में महिला बचत गटों के ऊपर करोड़ों रुपए खर्चा हो रहे, लेकिन आउटपुट देखा जाए तो कुछ भी नहीं निकला। बहुत सी स्कीमें हैं चल रही है, लेकिन जो लास्ट स्टेज तक है उसका उद्देश्य पूरा नहीं हो रहा। पहले तो ऐसा था कि जब सेल्फ हेल्प ग्रुप की निर्मित हुई तो हर ग्रुप को 20,000 रिक्वायरिंग मनी दिया जाता था कि उनको वो आपस में लेके कुछ उद्योग धंधा करे। फिर बाद में 6 महीने के बाद उनको 2 लाख, 3 लाख, 5 लाख तक उनको ऋण दिया जाता था। अभी हाल ही में जो अभी सिचुएशन है एनआरएलएम के थ्रू, कि वो 10 ग्रुप या 22 ग्रुप को इकट्ठा करके बड़ा लोन देके उनका आर्थिक उन्नति की जाए, इस तरह का काम चालू है। लेकिन जहां तक देखा जाए, जो नॉर्मल लेवल पे, ग्राउंड बेस्ड लेवल पे जो अधिकारी वर्ग है उनको रिस्पांस नहीं देता। मैं खुद जब इन गटों के माध्यम से इनसे वार्तालाप की, तो कई बैंकर्स उनको चोर के समान खड़े रखते थे 2-2 घंटा लाइन में। मैं जहां तक मेरा एक अनुभव है,
Sir, very sorry to interrupt you. एक मिनट, Hindu sir.
हाँ
Do you
बोलिए।
have any PPT to present?
नो सर।
Okay. So, okay. But what exactly tool you used? I think you will have to focus on that. What exactly tool you have used, and then we will talk about the findings and all. Okay. What was the objective of your study? That I understood, and all other ones also understood. So, आपको ये बताइए कि what was the tool of your study, and how you proceeded for that? The procedure of your study. Yeah.
ये सब स्टडी के लिए मैंने मुलाकात अनुसूची का उपयोग किया है, और हर बचत गट के प्रेसिडेंट से मिलके फेस टू फेस उनसे जानकारी ली कि बचत गट के माध्यम से गवर्नमेंट ने क्या करना चाहिए ताकि वो उत्थान हो सके लोगों का। तो इस तरह से जब डेटा कलेक्ट किया तो ज्यादातर गवर्नमेंट की जो ऑफिसर लाइन है, जैसे बैंकर्स है, बैंकर्स उनको ट्रीट बराबर नहीं करते। वही उनको बताते हैं कि इतना लोन भरो, इतना तुमको माफ रहेगा नहीं, तुम सब्सिडी खा लो, वो धंधा चले ना चले। और वो भी जितनी सब्सिडी उतना उनको प्रोवाइड करते थे।
इंटरप्ट करता हूँ मैं। सी दिस इज साइंटिफिक रिसर्च सेशन। ओके, हम आपसे ये जानना चाहेंगे कि आपने रिसर्च का कौन सा मेथड यूज किया, कैसे किया, कौन से टूल्स यूज किए, कौन सी मेथड्स आपने अप्लाई की, है ना? व्हाट वाज द प्रोसीजर ऑफ द रिसर्च, एंड देन वी विल बी एबल टू अंडरस्टैंड द फाइंडिंग्स ऑफ योर स्टडी। ओके, आपने क्या किया, कौन सा मेथडोलॉजी यूज किया, वो बताइए पहले, फिर क्योंकि टाइम अभी आई थिंक खत्म हो रहा है। भूपेंद्र सर।
हाँ, पहले तो मैंने वो सैम्पलिंग मेथड से चालू कर, यानी सैम्पलिंग मेथड से देखा जाए तो प्रोबेबिलिटी मेथड में से सिंपल रैंडम मेथडोलॉजी का उपयोग किया है। उसमें से उसके बाद डेटा कलेक्शन किया। डेटा कलेक्शन करने के बाद टेबल तैयार किए। टेबल्स में से कुछ फाइंडिंग निकले, जैसे कि आखिर क्या कारण है कि ये जो बचत गट का उत्थान हो नहीं रहा। बचत गट यानी
सैंपल साइज कितना सैंपल था आपका?
हाँ
Who were the participants and सैंपल क्या था?
हाँ,
आपने
तो वही
पहले से बात किया वो पता चला।
हाँ, सेल्फ हेल्प ग्रुप के प्रेसिडेंट इज माय पॉपुलेशन
सैंपल
हाँ
साइज
हाँ
वो रिस्पोंडेंट
sample size 361. I use the regular marking system.
हाँ, तो आपने क्या मेथड यूज किया टू कलेक्ट द डेटा और टूल क्या यूज किया?
टूल उसमें ये मुलाकात अनुसूची, इंटरव्यू शेड्यूल यूज टू कलेक्ट द डेटा।
इंटरव्यू शेड्यूल।
तो आपने क्या क्या इंटरव्यू शेड्यूल खुद से प्रिपेयर किया था?
हाँ, खुद।
तो कितने क्वेश्चंस थे, वो क्या थे, थोड़ा बताइए। हाँ,
उसमें 65 क्वेश्चन थे। गवर्नमेंट की स्कीम्स और गवर्नमेंट की स्कीम में क्या कमतरताएं है, इस टोटल उसमें इंक्लूड किया गया है। और उसमें से जो फाइंडिंग्स मिले हैं, तो उसके आधार पे मैंने वो जो एसएल बीएलबीसी रहती है, उनको भी रिकमेंडेड किया कि इस तरह से जो बैंकर्स है वो आम लोगों को जो जानकारी देना चाहिए वो दे नहीं पाते। और
समझ गया। चंदू सर, आपका
हाँ
5 मेजर फाइंडिंग्स बता दीजिए फ्रॉम दिस स्टडी। हम समझ गए व्हाट यू
हाँ
डन।
हाँ
5 मेजर फाइंडिंग्स बता दीजिए, क्या
एक
हासिल?
तो ग्रामीण, ये जो महिला महिला बचत गट है, यहाँ तक ज्यादातर पढ़े हुए महिला रहती नहीं है। और दूसरे यह है कि उनको जिस तरह से जो फैमिली सपोर्ट दिया नहीं जाता। तीसरा फाइंडिंग्स ये है कि आमतौर पे बैंकर्स उनको जिस तरह से ट्रीट करना चाहिए, एक एजुकेटेड महिला है, वो अपना काम सही तरीके से कर सकती है। उनको एक बार गाइडलाइन दिए, एक आधा नोटिस चिपका दिए, या ऑनलाइन की सिस्टम बोले तो ये सब कर दे। लेकिन जो देहात में जो गरीब लोग रहते हैं, महिलाएं रहती है, उन ज्यादा लिखी पढ़ी रहती नहीं, उनको सादी एप्लीकेशन लिखना नहीं आता, और उनसे वो ऑनलाइन की बड़े बड़े फॉर्म में से वो भरना, ये तो इसके लिए गवर्नमेंट ने वहाँ पे प्रोफेशनल ऑफिसर रखना चाहिए कि टोटली जब करोड़ों रुपए जो इस स्कीम पे लगा रहे हैं, तो उनको प्रॉपर गाइडेंस देना चाहिए।
ओके, अब एक बस एक बता दीजिए फाइंडिंग्स और हम रुकेंगे। ठीक, हाँ, टाइम इज ऑलरेडी ओवर। और क्या मेजर फाइंडिंग था आपका?
और एक मेजर फाइंडिंग्स ये है कि गवर्नमेंट ने भी ऐसा एक जोनल लेवल पे एक सोशल वर्क की अपॉइंटमेंट करना चाहिए, ताकि सोशल वर्कर अपने टूल्स और अपनी टेक्निक्स का उपयोग करके जो गरीब महिलाओं का उत्थान कर सके।
दैट इज योर रिकमेंडेशन ना, नॉट फाइंडिंग।
हाँ,
ओके
रिकमेंडेशन। हाँ,
ओके, ठीक है। आई थिंक आपको कुछ अभी बताना है, अदरवाइज वी विल कंक्लूड। भूपेंद्र सर?
नहीं, you can call the next one.
या
For me,
ओके
it is fine.
ओके। चंदू सर, आपने कभी इसके पहले पेपर नहीं प्रेजेंट किया कहीं पर?
नहीं किया था एक्चुअल। थोड़ा ये मेरा जो इधर थोड़ा प्रॉब्लम चालू था, एक तो उसमें प्रिपेयर नहीं हुआ।
प्लीज डोंट माइंड।
वक्त पे अभी वक्त पे किया।
Once we are presenting our things into the national
ओके
conferences,
ओके।
we must be, with
वैसे
well.
तो मैंने वो थेरोटिकली प्रेजेंट करने वाला था, लेकिन आज ये सुबह से अभी तक का जो प्रेजेंटेशन देखा है मैंने, उसमें
We
टोटली
respect,
रिसर्च पेपर दिखे। हाँ
Sir, we respect the people, those who are working practically in the field,
हाँ
but at least there should be 1-2 slide. On the basis of that, you might have, done well. Bhupendra sir, are you agreed with me?
थैंक यू सर।
Yes, Chetan sir, definitely I agree, and I would suggest Chandu sir, actually while making the list, I felt that actually he was with us in the last year conference also, and including you in the same session as a chairperson was to just facilitate or felicitate the local language if he wanted. So something was in my mind when I was or I intended to put you in his session as a
Good actually.
chairperson, so that if he want to communicate the things in a local dialects, and that could not be prevented in either manner.
That is really
But
appreciated, sir. Yeah, that taken care, that the care you have taken care. Okay. Yeah. So I think presentation wise, we will conclude. Is there any question for this presenter from floor?
we have one more presentation in this same session.
Okay, then we'll have to proceed next then. Okay, next presenter, please.
Ring grade Dow.
Hello, sir. Am I audible?
No, sir. Yeah. Huh. Ringred Dow Fonglosa, please.
Yes, sir.
Can you pronunciate your name, please?
Sir, it's Ring Dow Fonglos.
Ringred Dow Fonglosa. Yes.
Yes, sir.
Yeah, perfect.
Sir, is my slide visible?
Yes, it is visible now. Yes, please.
Good evening, everyone. My name is Ring Dow Fonglo, and I am currently pursuing my PhD coursework from Department of Social Work, Assam University. So today I'll be presenting on the topic transition from Jum to settled agriculture, a case study from Dima Hasao district of Assam. So this study focused on the Dimasa tribe. So let's go with the introduction. So Jum cultivation is one of the oldest and primitive. Excuse me, sir.
Hello.
Can't hear you, man.
Hello.
Yeah.
Continue your presentation.
Okay, sir. So Jum cultivation is one of the oldest and
go to the slides mode.
Is my slide visible, sir?
It's visible. You will have to just make it, little in a presentation mode.
Slideshow mode.
Go in design mode. See after one symbol. Okay, like a trophy, there is a symbol, no? Just click on that.
Yes, sir.
Below all. You can use either below or above. Otherwise, continue.
Continue as you are comfortable. Just continue.
No problem. You can continue.
Actually, I'm not able to see my slides right now. Okay, I'll just continue, sir. So with introduction, Jum cultivation is one of the oldest and primitive agriculture system commonly practiced in Northeast India. Its origin can be dated back to the Neolithic period around 7000 BC. Jum cultivation is most prominent in the northeastern hill region, and the practice is carried out over 1.47 million hectares of land and provides livelihood to 0.44 million people in the region. The practice is linked to ecology, culture, and economic of the tribal community, but in recent times, slow transition towards settled agriculture has been observed. In the early days, the cycle of Jum was 15 to 20 years, enough for soil to regenerate its property. But the increase in human population led to intensification of farming cycle, which led to the decrease of fallow field. Over the year, the increasing need for cash income among the hill farmers for education, healthcare, and daily consumption diversified, shifting cultivated land to home garden and multicultural plantation, particularly Erica nut. So, is the slide visible now?
Yes. Go ahead.
So, in figure 1, we can see that they are preparing the Jum cultivation, and in figure 2, we can see the Erica nut plantation. So, Jum cultivation is the primary livelihood of rural Dimasa community. The community practiced Jum mixed cropping, where they grew a variety of vegetables like taro, pumpkin, ash gourd, ladies finger, brinjal, chili, etc., along with cereals like paddy and maize. So in figure 3, we can see that they are preparing the land of June. At the same time, they are also planting small saplings of areca nut. So this indicates that there is a slow transition towards settled cultivation. So in figure 5, sorry, in figure 4, there are we can see the different type of land used by the household. So the household use have June cultivation where they practice mixed cropping. At the same time, they also slowly transforming it into monoculture settled cultivation. And also the household practice home garden. So the objective of the study is to understand the land use distribution of the household in the study area, to identify the region for continuing June cultivation, to explore the factor influencing the shift from June to settled cultivation, to explore the challenging factors limiting the transition among the farmers. So the methodology used here are the study area is Didaudi village, which is 8.8 kilometers from Maibang town, the subdivision of the Mahasau district, Assam. So the study was conducted by adopting the case study research design. The primary data were collected by interviewing 10 households employing semi-structured questionnaires. Household samples were taken by using a purposive sampling technique. Furthermore, focus group discussions were carried out with 10 respondents. So in findings, the figure 5 shows different land use distribution of the household. So out of the 10 households, 50, it is found that 50% of the household they were practicing June plus areca nut plus home garden, while 40% they were practicing June and home garden, and 10% they were practicing areca nut and home garden. So this 10% indicates that the household has discontinued June cultivation. So in the next slide, figure 6 show different regions for household continuing June cultivation. So the regions were cultural continuity, food security, followed by easier process. So these were the regions for continuing June cultivation. So in the next slide, that is figure 7 shows different responses of the households. The factors influencing shift from June to settled cultivation. So one of the factors is low crop productivity from June, followed by high productivity from the areca nut plantation, followed by high economic returns and decreased land availability. So in the next slide, the figure 8 shows different benefits of settled cultivation responded by the household. So the first one is increased income, followed by environmental conservation, climate resilience, and improved livelihood. So these are the results that we found from conducting focus group discussions. So the findings are the factors influencing transition. That is reduced fallow period, which includes soil degradation, shrinking forest cover, lower food productivity from June, and second, that is economic diversification, which includes high productivity from areca nut plantation, improved livelihood, high economic returns, followed by limited land availability, includes increased human population, modernization, and enforcement of wealthy households. So the another findings shows challenging factors limiting the transition. So this includes economic return and investment requirements, which includes long profit return, economic insecurity, and long yield period, followed by limited institutional support. That is, which includes lack of crop insurance, inadequate saplings, and not accessible to loan, followed by high labor and resource demands. So this includes increasing labor demands, need for pesticides, and higher management. So in conclusion, farmers have reported inadequate and inconsistent assistance with settled cultivation despite some government schemes. The shift toward monoculture plantation among the Dimasa community is not just by choice or influenced by policies, It is a complex negotiation shaped by environmental degradation, economic pressure, and institutional gap with profound implications for food security and rural livelihood. The settled cultivation provides long-term return with significant investment, labor, and time before yielding profit, making it inaccessible for the poorer demands of household without institutional support. So there are some of the limitations of my study. The sample collected is not enough to draw a concrete conclusion. More study focusing on the socio-economic and ecological factors are required, and study using the framework of vulnerability in the context of climate change is required. So these are my, yeah, thank you.
Yes. Yeah. Is there any question from the floor? Any question?
Please don't allow, you just conclude from your end.
Okay. So I think according to the topic, I could understand the zoom cultivation technique, which has been earlier used, and there are switch from this cultivation techniques, right? And people started using new technology, and there are some reasons for that. And you mentioned that economical things are there, then new switchings are there. It was required, I think, day by day. Am I right, presenter?
Yes, sir. Yes, sir.
Okay. So I think it could have been done, it is good, no doubt, the result-wise, conclusion-wise, but it could have been done in a real particular manner with aspect to the, the psychological developments, then what exactly other developments are there. Okay. Socio-economic conditions, how it improved, how it helped. Okay. Yeah. So the farm is there, no doubt. But along with that, there are so many other businesses done by the farmers. Okay. What kind of improvements are there? Is there any benefit, new, which is what we can say, easily understood or easily seen? Okay. That kind of findings, because I think around 10 samples you have taken, around 10 interviews you have done, right?
Yes,
10 interviews. Okay.
Yes, sir.
Yeah. So I think from these people, FGD also was there, good tool used by you. So from that, from FGD, what was the finding of you? Did you conclude into that? From FGDs, what was the major finding?
Sir, I think I mentioned it in the slides.
Can you please tell me in a bullet? One finding only. No doubt it was good. But what was the major finding from the FGDs?
Sir, even though farmers know that the advantage of shifting to settled cultivation, but some factors are limiting them to totally shift to.
I can understand. See what happens now with the green resolution and so many, the techniques used, the new technologies used into the farming. Due to that, people started using new technologies. Okay, they got into that. But I think we should be to the point, to the specific agenda. What was the proper improvements there, and what was the proper, the development? Are you able to mention from your results that these were the some useful conditions and helped farmers into their what we can say, drastic changes into the farming or pharmacological industry, we can say?
Sir, actually, I'm in the initial stage, so I'm not in a position to respond it right now. But in the future, I'll definitely increase the sample
But
size.
I think you tried well. That is good efforts taken by you.
Actually,
yeah. So
actually, at this stage, Chairperson sir, we have also done some work on shifting cultivation. This particular transition from MSW to PhD, we have done work in Mizoram. It's very interesting. At this stage, we cannot expect much more from the scholar. The thing is that we should have mentioned the context where we have done, and of course, for this conference he would have done some research. Even that we appreciate, actually. For presenting a conference, he has done a research. Maybe it may be part of his thing. I really appreciate the scholar. And, we have done some papers. In Eastern Anthropologist, we have published a paper based on purely MSW dissertation. And Journal of Social Development and Social Work published by Santiniketan Viswabharati also we have published. So we can consult our PhD thesis on shifting cultivation to settled agriculture and MPhil thesis also, which are available online. So good, this is a good area, the critical livelihood transmission that is happening in the Northeast, particularly among the, it is very interesting to know that highly profitable ventures, horticultural crops, they are happening. Horticulture is a hope for many.
But one thing I really want to appreciate here, that the farmer's grown, he has developed, the development, he was able to that catch the particular development. Okay, he mentioned, I think, in one of the slide that, see, by areas, by the land structures, that is understood. But what was the proper development into the lives, like, I think, livelihood, again, employability. So these things, I think, are mentioned by the presenter. And at this stage, I agreed with you, sir. At this stage, this is really appreciated, because being scholar, there are so many difficulties for the students to understand all these things, but I think he understood the concept. That is the reason he initiated this study. So good, I think finding was it is going to be really useful for government as well to make some policies, to create some policy decisions, okay, in the farming sector. Yeah, good. So with the permission of Bhupendra sir, I think 5 presenters have done their presentations. How many, sir? 5,
Yes,
no? One was not there. Yeah. So the presentation wise, it was really good. Last time also we have seen that students are coming forward, they are presenting. The topics selected by the scholars are really, again, good and appreciated, because see, in our field we can say that people are lacking. Kanagraj sir is also here, he is listening to me. People are not touching the patent point. Okay, we are doing so many things in the field of psychiatric social work and innovative things, like now people are talking about incubation and all. But incubation, innovative things, our scholars, our teachers are already initiating, but unfortunately we are not able to make the marketing of that. But from the 5 presentations, I could see that the innovative ideas, innovative things the presenters have mentioned. Okay, and again, the eye-opening stage is there for the government as far as policy making concern as well. Many things to be carried forward from this, many messages to be taken forward from these 5 presentations. So I think it was really useful and good presentation from last presenter as well. Okay, so with this note, I would like to conclude this session with the permission of Bhupendra sir, Honorable Secretary of ISPSW.
You are the chairperson, sir. I am just facilitator now.
Yeah,
so,
but I I wanted to just mention thanks to you. Yeah, thank you all of you again for joining. All the participants, Honorable Kanagraj sir also have joined, our president of ISPSW. I can see many professors, teachers, students also have joined. I believe all have enjoyed the session, the fruitful sessions. Thank you all of you for joining this session, and have a happy good evening to all of you. Thank you very much.
Thank you. Just one correction. Actually, Kanagraj sir has just he didn't join just. He is throughout the day with us. He is there from the very beginning. Even not today. He is with us from the last day, from the last morning to till now. He is continuously with him. Not only Kanagraj sir, many of us are here. All means continuously, persistently, and. Thank you so much, Chetan sir, for being with us and evaluating this session. Actually, I also would love to talk a lot, but I am already more than an hour delay from expected track. So here all the members, those who are member of ISPSW and here with us, please bear with us. Actually, it was expected to start our AGBM at 6, but because we have one more session to finish, so it may be delayed a bit. So our another session would be started on the same platform. Thank you, Chetan sir, for chairing the session. Now I would like to invite the chairperson for the next session, Dr. Rishi Pandey, Medical Social Service Officer at AIMS Bhopal, and Megha Atri, nursing, sorry, Megha Atri,
Good evening.
our
Thank you,
tutor
sir.
in psychiatric social work at Central Institute of Psychiatry, Ranchi. Just one amendment, although I know that I communicated to all the presentees that they have to finish their presentation in 8 minutes, but because of the structure means tight schedule of the time, and then I saw that few of the students, they are bit senior, so I just request if they can cut it down the time, that 8 minutes to 6 minutes or 5 minutes, that would be very good for the organizers. I would be thankful if they would reduce their time, and would like to request the chairpersons to please don't allow any further second from 8 minutes. Over to both of you.
Thank you, sir.
Hello. Would you like to read me the names for you? The presentee's name: Vikas, Sangeeta, Sanjeev, Asfaq Ahmed, and Techi Makeup.
Okay, sir. 5 presenter.
Yes.
So, sir, without delay, we should start presentation with your
Please.
permission.
Please.
So, the first presenter is Vikas Kumar.
I am audible.
Yes.
Yes.
Good evening, all of you. Myself, Vikas. Currently, I am working as a psychiatric social worker in Kalyan Singh Medical College, Bulandshahr, and also doing my PhD from RINPAS. Today, I'm present my topic titled "Locus of Control and Quality of Life Among Individuals with Alcohol Dependence," hospital-based study. Now, introduction part. Uh, slide. Okay. So, alcohol dependence is a chronic and relapsing condition that significantly affects an individual physical, psychological, social, and occupational functioning. It leads to a wide range of personal, familial, and social problems, including health deterioration, job loss, domestic violence, and social isolation. Individuals with alcohol dependence often experience a significantly impaired quality of life that reflects a person's belief about control over life, events, and outcome. The objective of the study to assess the different in locus of control and quality of life between individual with alcohol dependence and normal control, and to explore the relationship between them. Methodology. This is the cross-sectional study was conducted with 200 participants comprising individual with alcohol dependence and normal control, conducted at RINPAS, Ranchi. Data were collected using purposive sampling method and sociodemographic match with the experimental group. The participants were assessed using WHO brief quality of life and Lifeson scale for locus of control. This is the result part. This is table 1. Comparison of the table shows the comparison of sociodemographic variables of individual with alcohol dependence and normal control. There is no significant difference because of we match the sociodemographic with the alcohol dependence group. Table 1.2, comparison of age of individual with alcohol dependence and normal control. The average age of alcohol dependence and normal control group 32 years. This is the table 3, comparison of locus of control domains between individual with locus of alcohol dependence and normal control. The table shows the powerful others domain and the chance control domain have more score than normal control group. This show the uh, alcohol dependence group perception that external influences significantly impact the life events and by chance. And the individual control score is higher in normal control group than individual than alcohol dependence group. This show that the alcohol dependence group have limited control in individual control. This is table 4, comparison of quality of life among domain between individual with alcohol dependence and normal control. The table shows that individual with alcohol dependence reported significantly lower score across all the domain than normal control. It means individual with alcohol dependence experience significantly greater challenges in overall quality of life, including physical health, psychological, social, relationship, environmental. This is table 5. This show the relationship between locus of control and quality of life. So, quality of life, there is a negative correlation between the all domain of locus of control and all the domain of quality of life. Negative is a significant negative correlation were found between all the domain like powerful other chance control, but positive correlation between the individual control and quality of life. That means uh, the the participant who the alcohol dependence participant who have powerful others and chance control have poorer quality of life, and the who have individual control have less poorer quality of life. Discussion part. The present study found no significant difference in socio-demographic variables such as age, education, family type, religion, and domicile between individuals with alcohol dependence and normal control. This is because of normal control group was matched with the individual with alcohol dependence group. The study found significant difference in locus of control between individual with alcohol dependence and normal control. Those with alcohol dependence score higher in powerful others and chance control domains, indicating a stronger external locus of control. They tend to attribute life events to external forces like powerful people, faith, or luck. Conversely, they scored lower in the individual control domains, so reduced belief in personal agency. The study also found significantly lower quality of life score across all domains: physically health, psychological health, social relationship, and environment in alcohol with individual dependence group compared to normal control. The study found that a higher external locus of control is linked to poorer quality of life in all domains, while a stronger internal control is associated with better physical health, social relationship, and environment. This pattern is supported by previous studies. Thank you. Conclusion. Individuals with alcohol dependence have significantly lower quality of life and a higher external locus of control compared to normal control. Believing that life is controlled by faith, chance, or powerful other is linked to proper quality of life, promoting internal control. So, psychosocial intervention can help improve their quality of life and recovery outcome. Thank you.
Thank you, Vikas, for completing it in during the time period only. Uh, Anyone from the platform, online platform, wants to ask any of the question or any of the query?
What was the procedure for sample size calculation, Vikas?
Purpose sampling technique.
No. You came across 200 samples.
Yes.
So how you came across 200 samples? What was the sample size calculation formula you applied here?
No formula applied.
So how you reached to that 200 samples? Am I audible?
Yes, you are audible.
Yes.
Actually, this is my PhD research. So DRC members suggest me कि you have take 200 sample size.
Okay, thank you.
Abhijit, can I add on something?
Yes, sir. Please, sir.
Vikas,
Rishi sir and
what?
Megha, may I request Please don't allow any questions in between. Let them wait for the finish all the presentation and then open for the question answer session. And maximum two questions from one presentation, not more than that. Please keep in the mind. Now,
Okay,
please
sir.
proceed as per your comfort.
Sure, sir.
Can-
So should we proceed to sir another presentation or continue with this only with the opinions
At least
or queries from our side?
you started and open for the questions, so finish it. But later on, it is my request not open for the questions. Later, means after finishing all, then you can take questions.
Yes,
Sure,
Prashant,
sir.
sir, please.
It's not my question, it's just a suggestion to Vikas because it is the PhD research work. So for that, you have to go with some G power calculator because you have to do the sample size estimation which is very required if it is a work of PhD. So you should do sample size estimation rather the question will be arised in your viva might be. So that's the Abhijit is asking. Yeah, how you have decided to take the sample 200. So
Yes.
you have to do the power sampling or power calculator, G power calculator for that.
Okay, sir.
Again, Prashant, sir, just to add, again, we can also use Vikash. We have Craigie and Morgan method, one of the very oldest method as a sample size calculator.
Yes, yes,
That
yes.
also you can use to estimate your population. But again, I'll go with Prashant, sir. It will be difficult to defend in the Viva if it is not
But
taken care.
Abhijit, can
Yes,
I
sir.
add something?
Sure, sir. Please, sir.
Actually, if everything is going on and he has completed his study, so it is possible to use a sample size formula right now.
No, sir. Right now, it's not possible. So I just wanted to know that.
Wait. Please stop this discussion. I have only one comment.
Okay,
Actually,
sir,
you
I
all
have
have
one
completed your
question.
PhD and you must know that you cannot do anything against your DRC suggestions. Please keep that fact in your mind.
Because
Okay.
many people
Although
have
I completed my PhD before you, all of you, but I still remember that whatever I want to do, I cannot do anything against the DRC suggestions. So that
Sir,
applies
but
on the
sir,
Vikas as well.
sir, but how the DRC has been approved? That is the again a question
That
with power estimation without power.
Prashant.
I think there is one thing. No, it should be according to prevalence. Then
Okay, we will discuss later. Please,
Sir,
let
sir,
let
one question
chairpersons
can
manage
allow,
the session.
if chairperson can allow for one clarification only, not a question for Vikas PPT. I haven't found a p-value. Is there any p-value from your tables? Yeah, is there a necessary for p-value or only p-value is sufficient for the justifying the any result? Thank you.
Chairpersons, please ask next to present.
Okay, sir. So we invite to next presenter, Miss Sangeeta.
So sorry. May I audible? Hello.
Yes, yes, you are
You are
audible.
audible, but you are presenting something else which you don't want to, I think.
No. I just sorry for interrupting.
Hello, everyone. Hello.
Yes, Sangeeta, you are audible, Sangeeta.
Very good evening, everyone. My name is Sangeeta. I
But
am
sorry,
working
we
in.
are Sangeeta, we are unable to see your PPT.
Your slides
Still.
are not visible.
You just open your slides, minimize it, and again try to share the entire window.
My visible is available.
Yes, your PPT is available now. Just you can change to presentation mode if possible.
Okay.
There is a trophy-like button down your slide that you can click. Yes, that one.
Sorry for starting my interrupting some technical issues. Hello, everyone. Very good evening. My name is Sangeeta. I'm working in EVAS in a research project. My PI name is Dr. Arif Ali. Today, I'm presenting my in-depth interview case study. I starting my title topic, breaking the cycle of case study of interplay of trauma, addiction, and homeless in a shaping in a criminal behavior. Yes. Methodology I used. This case study employed the qualitative approach and explored the complex interplay between the trauma, addiction, mental health issues, criminal behavior, lifetime individual experience. Methodology used by detail the in-depth interview analysis, Mr. SB Live drawing on the primary and secondary resources, understand the interconditional in various socio-economical and psychological behavior factors. SB was selected the case study due to this complex history involving childhood trauma, substance use, mental health struggle, and individualment in criminal activities. His experience provide representative example for these factors, converse and protection the cycle of violence. This case studies history. Mr. SB 45-year in Delhi based person, life shape in trauma, addiction, and crime. Earlier life raised the violent, emotionally neglecting home, exposed the alcoholism and crime. Pivotal in trauma, charge in father murder during the college, unresolved case lead guilt, anger, and stability. Marriage life and family life. His first marriage arranged and avoid the police sections. And these are there are many. Uh, he is married, but otherwise they are very involved the inter relations, and there are many extra affairs. So there are many difficulties in family, emotionally imbalanced person. And relationship making the difficulty of substance use, domestic violence, second marriage ended. Criminal life. Criminal life activities in organized crime, cable, mafia. Uh, these are like criminal life, and these are very involved. Some gangs and student life. They involve the politics in college and some kind of crime. Then involve the family history issues. They multiple criminal life history in person during the in-depth interview. Legal challenges, multiple charge including the murder, and briefly in the manipulation with the criminal justice system, resolve them in manipulating the legal system, bring the jail staff and seeking the connection for the person. This person is I'm in-depth interview. This time they are saying कि I am a फरार, कि मैं छुप के रह रहा हूँ यहाँ पर, और like that कि I have a lot of criminal background this time also I have some charges and in my jail मैं वहां से भाग कर आ गया हूँ या मैं छुप कर रह रहा हूँ. तो like this kind of mindset and behavioral patterns, so very normalize this person, this pattern. They know internally inside ki this is the wrong, and what is the impact in society, in your socialization system. This slide is psychosocial determination, cycle of violence and crime. Expose the childhood violence and unresolved trauma, father's mother feud, lifetime involvement in crime, addiction and behavior, substance use, alcohol, drug, impaired judgment, increase the aggression because they cope of emotional pain, mental health struggle, untreated mental illness compounds by addiction, lead the disordered thinking, violent outbreaks, and failure engage therapy. Family trauma, toxic family dynamic and emotional stability, marked by violent relationship betrayal, the multiple lose enforced trauma and aggression. Revenge the misplaced the justice. Persist the related is the action, the form and the justice and reflect deep psychological bounds, emotional neglect and moral disorientations, social economical decline, progressive lose livelihood, social standing, housing due to the crime, addiction, damage, relationship, culminated the homelessness as instability. Conclusion. Sorry, one slide is missing. Sorry, this slide also include addiction and mental health. Addiction and mental health, long-term abuse of alcohol, sulfa, ganja, corex, and tobacco. Substance use linked the aggression, paranoid, and emotional numbness. Reported the violence is behavior under the intoxication, including the siblings and his wife. Diagnosed with mental health disorder in a jail, treatment in dread by addiction. Hello.
You can finish your conclusion slide. Findings, conclusion, yeah.
Yeah, this is conclusion. Complex interplay the factor the SB life reflect the treatment, trauma, addiction, mental health illness, influence the destructive and cycle violence in criminal behavior and social inclusion. Need to earlier intervention, timely psychological support, mental health care, substance rehabilitation could be have altered his life and trajectory. Important the convention support, sustainable recovery required the integrated service addressing just psychiatric and need and also housing, employment and social integration. Call for the SB has reminded the urgency and the develop the implement holistically, and these are reference secondary based data, like understand to what is the behavior pattern and what is the impact of his life, and some over completed my presentation. Thank you.
Thank you, Sangeeta.
Thank you, ma'am.
So should we move to another presentation, sir? Rishi, sir.
Third presentation, Sanjeev Misra. Sanjeev Misra. Sir, I
Yes,
think
sir, I'm
he's
here.
not.
Yes, sir. I'm audible, sir?
Yes, you are audible.
And the slide is visible?
Let the Sangeeta first left the presentation. Hello,
Actually, it's
Sangeeta.
presenting for Sangeeta Misra. Sanjeev Misra. Oh, sorry. Right now, it is.
Good evening, all. I'm myself Sanjeev Mishra, working as a medical social worker under project at IBAS. This review is presented by me and supervised by Dr. Arif Ali, who is the associate professor at IBAS, entitled as Violence, Criminal Behavior and Victimization Among Homeless Individuals with Severe Mental Illness, a narrative review. Coming on the introductory part, homelessness remains one of the most visible indicators of social exclusion, systemic failure among the homeless individual living with the severe mental illness, including schizophrenia, BPD, and
You can continue like this also. Considering the time, you can continue like this also.
Sure, ma'am. These experiences are not isolated phenomena, rather than they are shaped by the interplay of early life trauma, systemic neglect, and lack of coordinated of mental health services and societal stigma. This narrative review explores the prevalence and correlates of the violence, victimization, and criminal behavior among the homeless adults with severe mental illness. Coming to the methodology part, a comprehensive literature research was conducted to identify empirical studies examining victimization, criminal behavior, and associated psychosocial factors among homeless individuals. The such strategy was used encompassed 4 major electronic databases: Medline, Embase, PsycInfo, and Web of Science. The studies published between 2000 to 2024 were considered, and major keywords were used as homelessness, severe mental illness, violence, victimization, and criminal behavior. Coming to the inclusion and exclusion criteria, then empirical research were included, which can be quantitative or qualitative, and mixed method research focus on the individual experiencing homelessness who had a diagnosis of severe mental illness and report to outcome related to violence, crime, victimization, and criminal justice involvement. And study was excluded if they had focused on the exclusively on substance use without addressing comorbidity of severe mental illness, and including population with no clear indications of homelessness or severe mental illness. Data extraction part was title and abstract was screened independently by the two reviewer, and full text review are assessed by the eligibility based on the inclusion and exclusion criteria. Discrepancy were resolved through the discussion or consultation with the third reviewer. Data were extracted and study characteristics, samples, demographic, type of severe mental illness, definition, and measures of the violence, crime, and victimization as a key findings. Synthesis approach. Given the heterogeneity in the study design, setting, and outcome of measures, a narrative synthesis was applied. The findings were grouped thematically under the broad category of the violence, victimization, and criminal justice involvement and psychosocial correlates. Prevalence of violence and victimization. Studies have consisted shown high rate of victimization among homeless individuals with severe mental illness. Study in 2017 reported that over 60% population has experienced physical and sexual assault within 12 months. Victimization include robbery, physical assault, and sexual assault occurred in shelter or public place through the exploitative relationship. Gender plays a significant role. Homeless women with severe mental illness are more experienced sexual violence, especially in the shelter home environments. These traumatic experiences often exacerbate mental health symptoms and individual towards substance use as a coping mechanism. Pathways to criminal behavior. Although public narrative often depict homeless individuals with severe mental illness as they are more often victims than perpetrators. According to Patterson et al. 2014, when criminal behavior occurs, it is typically embedded in the struggle for the offenses such as theft, petty trespassing, or minor altercation are the often untreated psychotic symptoms and behavioral disability. A longitudinal study by Fisher et al. 2008 for homeless itself was a strong predictor of criminal justice involvement and independent of other variables. The role of early life trauma. The connection between adverse childhood experiences and adults such as mental illness, homelessness, and criminal behavior is well established. Early trauma, including abuse, neglect, and household race, neurodevelopment, and stress regulation systemic contributing to the emotional reactivity and impaired impulse control. According to Fisel et al., demonstrated that childhood abuse and neglect significant risk of both psychosis and violent behavior later in life stage. These early vulnerability also contribute that development of maladaptive coping strategies and independent difficulties, increasing the risk of re-victimization or participation in exploitation. Comorbidity with substance use. Substance use disorder are prevalent among homeless individuals with severe mental illness as a form of self-medication. However, long-term use exacerbates psychiatric symptoms and increases risk disabilitation and victimization. According to North et al. 2017, substance-induced psychosis can mimic the context with primary psychotic disorder, complicating diagnosis and treatment. Furthermore, many shelters or psychiatric services exclude individuals actively using substance, thereby excluding some of the most vulnerable individuals from the care. The confluence of mental illness, homelessness, and criminal justice environment underscores systemic deficiencies. Deinstitutionalization without adequate community-based services has led to increased exposure of mentally ill individuals to street violence and criminalization. In India and other low or middle countries, the shortage of trained mental health professionals and rehabilitation facilities further exacerbate this crisis. Jails have increasingly become the de facto mental health institutions despite being ill-equipped to provide appropriate psychiatric care. Many individuals cycle through incarceration without receiving long-term treatment and rehabilitation support. About the gender inequality and intersectionality, the interlinking of multiple forms of oppression such as race, gender, and sexual identity offers an important lens. Black men with schizophrenia are more likely to be criminalized and experience police violence in the US context. LGBTQ and plus individuals, particularly transgender women of color, face disproportionately high rates of and housing exclusion. Promising approaches and interventions, research support indicated models that provide both housing and psychosocial support. The housing
Please
first model.
conclude.
Sure, sir. Their intervention include trauma-informed care, peer support services, diversion programs, multi-sectoral collaborations. That implication to be need in the policy level. Policy must prioritize cross-sector collaboration and sustain investment in community-based mental health and housing services. In India, implementing the Mental Health Care Act and strengthening DMSP program can be programmatic framework. And in conclusion, the intersection of homeless, severe mental illness, violence, and criminal justice environment represents a profound public health and human rights challenges. Individuals with severe mental illness are far more likely to be victims than perpetrators, yet systematic failures often criminalize their distress rather than offer support. The trauma-informed multi-sectoral approach is essential and is to dismantle these cycles. Integrating stable housing with mental health care, peer support, and legal advocacy not only alleviates suffering for but fosters public safety, community resilience. I would enclose the ICMR and psychiatric research structures, intervention and implementation in India. Thank you, sir.
Thank you, Sanjeev. Now we will be moving forward to next our presentation, and then we will be taking all the questions at the end of our presentations of the session. Thank you,
Next
Sanjeev. You may
present.
left now. And next is Mr. Ashfaq. Mr. Ashfaq. If he is not here, then can I request to last participant to present first?
Ashfaq is there. Anyway, we call you the next, please.
Tacky, yeah. Thank you. You may start, please.
Yes, I think my slide is visible.
Yes, your slide is visible.
Good evening, one and all. I'm Pechi Makeup, a research scholar, psychiatric social work from Ranchi Institute of Neuropsychiatry and Elite Science, Ranchi, Jharkhand. So the title is Role of Family Focused Therapy in Enhancing Quality of Life Among Patients of Bipolar Disorder and Their Key Caregivers in Context of Frequent Relapse. Coming to the background, bipolar disorder is a relapsing and remitting psychiatric illness. Even a patient receiving, 1 second. I'm sorry, my slide has been on somewhere. I'm resharing it.
It is visible.
Okay, I don't know from my side.
It is visible, and from your end, please make sure that you
Yeah.
complete in the time only, given time.
Yeah.
Yeah,
Yeah,
thank you.
from
You
my,
may start.
yeah. Yes, something has happened from my end. I couldn't be able to see the slide.
You may read out from your mobile phone or another gadget where you have shared, or you may start again also.
Actually, reshare again. Stop sharing and then reshare again. I think you will be able to present.
Yeah. Give me a second. Yeah, sorry for this interruption. Yeah, coming to background, bipolar disorder is a relapsing and remitting psychiatric illness. Even patients receiving optional medications are likely to have multiple recurrence and to have trouble holding jobs, maintaining relationship. The behavioral and emotional experience of the person with bipolar disorder affect everyone, including the spouses, siblings, and children. The family environment is an important context for understanding the development and maintenance of severe psychopathology and mood disorder in particular. Family-focused therapy is an integrative approach that offers promise for improving the well-being of caregivers and patients with bipolar disorder, emphasizing the significance of involving families in the treatment process. It promotes understanding of illness, vulnerability, stress model, and patient's inner experience, emphasizes the importance of medication adherence, improve communication between patient and family with concrete strategies. Key caregiver are the primary source of support. Few studies in Indian context have focused on family-focused therapy seeks to reduce the high level of stress and conflict in the families of bipolar patient, thereby improving the patient illness course. At this junction, we'd like to explore and implement the effectiveness of family-focused therapy among key caregivers. The objective of this study is to assist the family-focused therapy in increasing the quality of life for key caregivers of bipolar affective disorder and patients of bipolar affective disorder with a history of frequent relapse. Hypothesis, there will be no significant difference in the quality of life of family-focused therapy and treatment as usual group. Material and method, the venue of the study was conducted at Ranchi Institute of Neuropsychiatry and Elite Science. Case control study was designed. Criteria-based purposive sampling technique was used. A total of 20 caregiver of patients with bipolar affective disorder divided into two groups, experimental group and control group, each consisting of 10 participants. Inclusion criteria for the key caregivers, carers living with the bipolar affective disorder patient in the same household and actively involved in patient's care. The duration of patient care was more than 2 years. Carers had an educational background of minimum fifth standard. age range between 20 to 45 years, willing to give written informed consent was taken in the study. Exclusion criteria for the key caregivers: carriers with an educational background of below fifth standard. Age range is below 20 or above 45 years. Carriers are not staying with the patient in the same household. Providing care to the patient less than 2 years. Exclusion criteria for the patients. Inclusion criteria for the patients: diagnosed cases of bipolar affective disorder according to the DCR of ICD-10, history of frequent relapse, 2 or more episodes in 1 year, age range 20 to 50 years. Exclusion criteria for patients: patients with comorbid epilepsy, intellectual disability, other psychiatric disorder, chronic physical illness, and neurological disorder. Age range below 20 or above 50 years, patient having diagnosable addiction to psychoactive substance bearing nicotine. Tools applies was WHO quality of brief Hindi version. Coming to the result, quality of life in a bipolar affective disorder patient and caregivers comparing experimental group and control group. Quality of life has been assessed statistically in experimental group and control group by using t-test to compare the means of two populations. So the table represents the result on quality of life before treatment, after treatment, and during the follow-up in two groups. Quality of life has been assessed in terms of 5 aspects or dimensions, namely general health, physical, psychological, social, and environment. Prior to the treatment, the differences in the quality of life among caregivers and patients were comparable in all dimensions, with no significant difference existing between the experimental group and control group, except in the case of the general health of caregivers. Quality of life differences among caregivers and patients in experimental group before treatment: significant difference found in the dimension of psychological, while there were no statistical significant difference between patients and caregivers in other aspects. Post-treatment and follow-up, no statistical significance were found. A quality of life difference among caregivers and patients in control group. There were no statistical significant difference in quality of life amongst the patients and the caregivers in 3 scenarios: pre-treatment, post-treatment, and follow-up. Comparison of quality of life and general health between caregivers and patients in 2 groups, where this table shows Wilk lambda values and partial eta figures for measure are also given, but found to have no statistical significance. Should I indeed? Coming to the conclusion, primary treatment for bipolar disorder are pharmacological, adjunctive, psychological intervention have addictive effect in relapse prevention. So it could be interesting to carry out a study with a large sample size so that the possibility of generalization of result can be achieved. Further, there should be some research to consider the barriers to implementing a family or other psychosocial intervention for bipolar patient in community setting, and also include family, whole family members. Thank you.
Thank you. Sorry for the mispronunciation of your name, Tachi. Makeup.
It's fine. Yeah.
Thank you. And you can leave your presentation now. We will be taking question answers later.
Okay.
Mr. Ashfaq.
Hello, good afternoon, everyone.
Good evening.
Actually, good evening. There was a problem in my slide sharing earlier. Is my slide visible in this? Is my slide visible?
Yes, your slide is
If
visible.
there is any issue, proceed further.
Oh, Okay. Good evening, everyone. My name is Ashfaq. I'm a resource scholar in Department of Social Work, University of Delhi. The title of my presentation is Social Work Intervention in Prevention of Lifestyle Disorders. Introduction about slide is lifestyle disorders are the leading cause of death. As per the WHO, 75% of global deaths are due to the cardiovascular diseases. And mostly it's from the lower middle economic countries. Lifestyle disorders, diabetes, heart disease, obesity, and hypertension, sedentary lifestyle, and poor diet accelerates to aging and quality of life. Social work in healthcare, this is bit related to the lifestyle disorders. That's why I put the slide here. First medical social worker was appointed in 1946. We know all that. General involvement, I will not read all the slides in the detail because it will be a little bit time taking and consuming. We'll go through the
Yes,
points
yes, yes.
and
Thank you so much.
so that the general involvement we engage
Spark, your voice is not clear.
the individual and community health, focus on the promotion and treatment disease as a social worker, and believe in the well-being and uh, target specific illness and it okay. Sir, is it now clear now, sir?
Yes, yes,
It
clear.
might be, sir, network issue, sir. Intervention at different level, family level, and community level and policy level. Is it, sir, audio clear? Okay, okay, sir. The rationale behind this study was that in the last past, get significant increase in the lifestyle disorder and comfortable our life. Most lifestyle disorders are preventable through early intervention behavior education. Objective of this paper based on the review to examine the role of social work intervention in prevention of lifestyle disorders and find out the psychosocial intervention which previous studies have been done, which are mentioned in the slide in the next slides. The methodology Prisma guidelines were followed. First, we identify the papers.
Gone.
Sir, actually, there is, I think, network issue. This slide sharing is closed. These are the databases used in the study. Google Scholar, PubMed, Web Science, and the social terms were used to identify the literature was lifestyle, social work, and intervention. Data extraction and management abstracts were reviewed in initially relevance. The first author determined the initial eligibility of the studies, reviewing the titles and abstracts. Study appears to meet the inclusion and exclusion criteria were further reviewed. The second author also made the final list of the selection studies in the inclusion. This the inclusion and exclusion criteria of the studies which were included in this research. Mostly random RCT and studies which include the non-pharmacological management, focus on intervention and lifestyle changes, intervention with groups and individuals, and published between 2010-23, community-based studies. Excluded were papers before 2010 and papers were not in English and not having the community-based intervention related. The flowchart of the study that papers were examined 320 papers from Google Scholar, 330 from 230 from the PubMed and Web of Science 77. Out of which 271 were excluded because not having the relevant titles and all. 375 were excluded after screening the abstract and 71 were included for the full assess. out of which few studies were also excluded because they were not providing the non-pharmacological intervention and appropriate design was not. Outcomes were not met in the 8 studies. So final study of the list was 14. These are the studies which I have included in the list. The intervention were provided in all the studies, that psychoeducation, motivation enhancement therapy, CBT. And the second study, 10 group session were done. Third was semi-structured interview, health monitoring week program, 12 months intervention, and 6 dietitian-led lifestyle sessions were done in this study. Weekly session, one group session was in another study. 16-hour session was in another study. Physical and social cognitive spiritual interventions were done in another study. 64 was diet-based and exercise, stress management, and other 6 months intervention studies were done in another study. Psychoeducation to individual and groups and home-based patient lifestyles outcomes were in the other study. 1 year intervention in other study. So based on these all studies, I have found the results section I have mentioned because the paper is trying to examine the role of social work intervention. The results were, first I found the advocacy as a role of social worker, psychoeducation about the healthy lifestyle, because this will help the family and the patient to prevent at earlier stages. Self-care and developing coping skills, eliminating the negative coping strategies which we deal in the day-to-day sessions in the OPD basis or inpatient basis. Active listening, family interaction pattern, family may examine the general relationship dynamics impact the behavior of the family members. Community resource mobilization is also social work intervention. Stress control intervention, which we use in the session, stress management intervention. Social support intervention. Risk factors identified were sedentary lifestyle, poor dietary habits, tobacco and alcohol use, chronic stress and mental health, lack of preventive health checkup. These are the risk factors which lead to stress, lifestyle disorders. In conclusion, social workers play the key role in all the health, prevention, primary, secondary, and tertiary. Their cultural competence enhance the multicultural health promotions. They address the psychosocial risk factors. Lifestyle disorders use multidisciplinary approach. Social workers are vital team members. Early intervention at community level can help to improve the lifestyle. The promote healthy parenting and child guidance clinic. Non-pharmacological support by social workers is crucial to increase the digital lifestyle challenges. Thank you.
Thank you, Ashfaq. We can start, sir, taking questions from the platform, and there are questions also in chat box. Rishi, sir, over to you. However
Okay.
you want to proceed further for this.
Okay, thank you, ma'am. We can allow 2 questions for each presentee.
For Mr. Ashfaq, I have one question. Ashfaq, during your review, what are the Boolean operators and keywords you have used in the advanced search option? Can you explain on that?
Keywords I have used social work and intervention and lifestyle, which I have used in 3 databases mentioned in the methodology slide, I think so.
And what about the Boolean operators you have used?
These are, sir.
Am I audible?
Yes, sir. These are the databases used in the to find out the relevant.
No, that I got. I just want to know what are the Boolean operators you have used in your review.
Sir, not getting the questions.
Not getting. Okay.
Okay.
Thank you, sir. Though questions I think have been done from the platform for the Ashfaq. Any questions, Rishi sir, from your side to him?
No question my side. Any other question for other presentee?
First, we had Sir Vikas. Mr. Vikas. The study name was Locus of Control and Quality of Life among Alcohol Dependent Syndrome Individuals. Any question from the platform, from the audience on this topic from this participant?
Yes, I asked to Vikas regarding p values in his table. If is there any
Yes.
clarity why
Vikas,
he
if
is
you are
not
here.
presenting p value in his table?
I thought that you might forget in all the presentations, but you still remember your question.
Sir, I still 4-5 questions for each presentee, but I asked one question to each. If you will
Okay.
allow and your time is allow.
No, actually, that is up to the chairperson. I'm not in the picture, but I was
Yeah,
hoping that
then I
he might.
request to chairperson ki at least allow me a few questions and few
One question
clarifications.
is allowed from your side.
Some questions have been put in the chat box.
In which table, sir?
But my question is if Vikas is here. I'm not able to see him
Yes,
anywhere.
I am here.
Then we can ask
He is here.
next ISSW conference to Vikas.
Sir, in which table? There are
Your all tables, because I am not getting a p value in your all tables, 3, 4, 5 tables. I think p value is there, 3-star is there. There is no indication for 3-star. Okay,
Yes, sir.
only p value cannot justify your results. You need to put p values. It will show in how much the probability is for the significancy or not significancy. As per my understanding.
Yes, sir. In table there are no p value. The indication the 3-star and 2-star.
Okay, okay. So one question for the Mishra, Sanjeev Mishra.
First, we will
I just
complete
put in chat
from
box.
the Vikas. So if there is no question from the audience to Vikas, so I would like to ask one question just from the Vikas. So as you are working with this clinical population as well, maybe on regular basis, so I just want to ask one question that how locus of control, we know that it impact the quality of life through the interventions we provide to the patients and the to provide to the patient. But my question is ki how this locus of control can help clinicians, therapists to improve the quality of life while planning or formulating any management plan for individuals with alcohol dependence syndrome.
Okay. When we look, there is a two type of locus of control, external and internal. The patient, yeah, people have the external locus of control. They believe their action controlled by powerful other or by chance or by luck. So in the patient who consume alcohol, abuse alcohol, so they relapse because they believe कि this action controlled by others, like when his friends and someone offer drink, he can't deny it for this. So when we improve their uh, internal locus of control, so might be patient maintaining their relapse.
So any technique to improve the locus of control or to work on the locus of control of the patient?
This is cheating with Vikas. Actually, it was decided to two questions. Now I think it is more than that.
Okay, sorry, sir. Thank you, Vikas. So we can move forward from the to the next participant. Sangeeta, the title was Breaking the Cycle. Case study on interplay of trauma, addiction, and homeless in shaping criminal behavior. Any question, any query, or any contribution suggestions to this participant from the
Yeah, I want
audience?
to ask just clarification from the presentee. In their history, is there any sexual violence in their childhood trauma or in any availability? I think maybe I forgot, but if is there any issues regarding this? Have you asked or have you got any information? Childhood sexual abuse or trauma?
May I audible, sir?
Yes, yes.
Sir,
Chairperson.
in a childhood trauma and family trauma, not particular sexual abuse or trauma, is family trauma and some social discrimination trauma and socialization trauma, not like physical or sexual trauma.
Okay.
Rishi
I
sir,
have one question. I have one question. Can I ask?
Prashant sir,
Yes.
sorry, we are 45-minute delay from our
It's okay.
AGBM.
It's okay. It's
And
okay.
the
I have
people
got
are insisting from there that they are actually, that is on another link. So they are waiting in
Okay.
another link and we are stuck over here. So I'm really sorry.
It's okay. It's
Chairpersons,
okay.
please conclude from your end.
Sir, this is the
Okay, sir.
tremendous achievement because in physical conferences we late for 2 hours and 3 hours. If in this is only 45 minutes, that is okay, I think.
No, actually that link and the people, those who are waiting to be enter, that is another challenge. Chairpersons,
Yes, sir.
please
Please.
conclude.
Okay, ma'am, please conclude.
Thank you all the participants for presenting the paper and wishing you all the very best of luck for your future research and may your all of the future researches and the present researches as well will be useful for the clinical implication and for better knowledge also for the others as well. Thank you, sir, and thank you all the participants. Best wishes. Thank you, sir. Rishi, sir, over to you.
Thank you, sir. Very informative session and unique topic for the presentee. Best wishes for all presentee. Thank you, Bhupendra sir.
Thank you. Now I feel that I am the one who need best wishes, but others are getting except me. Anyway, thank you, Megha and Rishi sir. And sorry, in the introduction part of the Rishi sir, actually I missed that P and M. So now I would like to correct that one. Psychiatric social welfare officer rather to medical social service officer. है ना? Okay, thank
Thank you,
you
sir.
one and all the presentees and both the chairpersons. Thank you so much.
Thank you, sir.
And others,
Thank you, sir.
please be with us for just a minute. I'm just stopping this live streaming and starting again to make it different session for the recording and